My name's Tom Stelfox, and as Scientific Director of the O'Brien Institute for Public Health, it gives me tremendous pleasure to welcome you to today's Gairdner Symposium. I'd like to acknowledge that today's symposium is being held on the traditional territories of the people of Treaty 7 region in southern Alberta. This includes the Blackfoot Confederacy, comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, as well as the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The City of Calgary is home to Métis Nation Alberta Region 3. As you listen to the research today and its impact on health, it's important for us to recognize that we're really at the beginning of an important journey going forward to do this work in partnership with our Indigenous peoples as part of Truth and Reconciliation, which the O'Brien Institute is committed to. The O'Brien Institute for Public Health is a research institute housed here in the Cummings School of Medicine at the University of Calgary. We've got over 1,000 members, many of you here in the audience today, spanning every major faculty and school at the university. We aim to function at the interface of society and the university, conducting really applied research with the goal of using evidence to inform the health and wellness of our population, and then to inform the healthcare system so that it can be there to catch us when we need care. I want to thank David and Gail O'Brien, the naming donors of our institute. They're inspiring donors and champions of research excellence to advance public health. And it was actually their idea that we think about hosting a Gairdner Symposium, which resulted in today's event. For any of us that have ever wondered about the impact of research, I think all we have to do is reflect on the last 3 years. And it's clear the importance research has on public health. And today we've got two incredible keynote speakers who have created new knowledge and have used knowledge to directly influence the health of thousands, if not millions of people. We've got Dr. Deborah Cook, who comes to us from McMaster University, whose research spans qualitative methods to quantitative methods, uses focus groups, large observational studies, all the way out to large international randomized control trials. I can tell you as a practicing intensive care physician that every day that I work in the ICU, some of my decisions are informed by the work that Dr. Cook has done. We have Dr. Verna Yiu, who really has been a champion and instrument in implementing a learning healthcare system approach into Alberta Health Services. And during the pandemic, I think we all saw, certainly those of us that worked in the healthcare system, the importance of timely local data matched to rapid synthesis of published research to inform decision-making at the most senior levels to try and guide us through that public health emergency. I want to thank the Gairdner Foundation for making today possible and bringing together these two incredible speakers. The Gairdner Foundation is responsible for Canada's preeminent health research awards. And we're really honored to host today's symposium, and I hope that you'll be inspired by the stories you hear. I want to briefly, please indulge me, I want to briefly share with you my one Gairdner story. So this past year, I had the good fortune of being invited to the Gairdner Gala. Can you hear me still? Yeah. Being invited to the Gairdner Gala as a member of the University of Calgary contingent. And it was a spectacular evening, right? It's just so inspiring. And one of the things that I thought was really good that the foundation did is it invited trainees. There were trainees there from high school all the way to postdoctoral scholars. And as we were waiting for the ceremony to start, I had a chance to chat with an undergraduate student from the University of North Carolina. And she asked me the question, she said, "What's the coolest research you're involved in?" And there was a moment of panic because I thought, what am I going to tell her? And then the answer was obvious. The answer is the coolest research that I'm involved in is the small window that I have into the research that the O'Brien Institute members conduct. And I really look forward to the day when one of our members has their incredible research recognized with a Gairdner Award. So what I'd like to now do is hand it over to Dr. Janet Risson, who's President and Scientific Director of the Gairdner Foundation. She's an internationally recognized stem cell biologist who received many recognitions and awards, and I'm just going to highlight a couple. 2018, she won the L'Oreal UNESCO Award for Women in Science. She has 7 honorary degrees. She's been elected into multiple societies, including the Royal Society of London in Canada, as well as the National Academy of Health Sciences in the United States. So please join me in welcoming Dr. Rasson.
Would you like to play it right away?
I've got my trusted assistant here to help me. So thank you, Tom. It really is a pleasure to be back in Calgary in person. It has been too long. And it's really, from the Gairdner Foundation point of view, our visits across the country to all the different universities are really an exciting part of what I do as president, because we do give awards to the best biomedical research that goes on around the world. But we also want to use that recognition of excellence to reach out to researchers, to students, to the public across the country to emphasize how important research is for our future. And I think everything that Tom just talked about in terms of the O'Brien Institute illustrates exactly how important that is, and that public health, as we have discovered in the last few years when we've not been talking to each other in person, is incredibly fundamental to everything we need to do as a society going forward, and to ensure that it is applied broadly across our population, including particularly outreach to Indigenous groups. So the Gairdner Foundation gives out international awards. We've been around since 1957. Over 400 awards have been given, and over 90 of those people have gone on to get the Nobel Prize. And as you'll hear in a minute, Deborah is one of the Gairdner awardees. Let's play the video.
Tonight, we celebrate you and your incredible research that inspires us all and is changing the future of medicine. Cheers.
Being a Gairdner Award recipient is a life-changing event. A lot of the program is very inspirational to the next generation of scientists.
The biggest excitement is really sharing what we do with others.
Finding and fueling that passion, I think, is key. This research, for most people, it's a long game.
Well, that's all it was. Was it worth it? So this summarizes some of the things I was saying. So that was the gala that Tom was talking about, and it is the culmination of the year for us at Gairdner, when all our awardees come to Toronto and we have a fantastic celebration. But as I say, Gairdner has been around since 1957. Every year we give out 5 international awards and a Global Health Award. Last year, Deborah received the Canada Gairdner Wightman Award, which was given to a Canadian who's made major contributions to science and research and impact on health in Canada. And she was, in fact, perhaps the last awardee of the Wightman Award, because this year we've put that award aside for the moment in order to recognize younger investigators. Sorry, Deborah. I'll try that again. Let me put it a slightly different way. We've decided to really try to recognize mid-career investigators so that we can really encourage researchers in Canada to reach forward, to reach the international level. And I will be looking to the University of Calgary to nominate mid-career investigators for the Momentum Award for next year. We gave 2 awards. We announced our awards last week, and if you haven't seen them, you can check out the video on our website. And the 2 first Momentum awardees went to Dr. Chris Musquatch, who's from Northern Ontario, working on Indigenous health, and Dr. Gelerazade, who works on brain cancer in Toronto. Fantastic, inspirational mid-career. But really, honestly, all our investigators, all our awardees are inspirational, and it's our role in the Gairdner Foundation to bring them to you, to Canada, to these kind of events, and I'm very happy to be here. I'm now going to hand it over to Kirsten, who's actually going to introduce Deborah.
Thank you. Thank you so much, Janet. It's my absolute pleasure to be here today for this wonderful event. So I'm just going to give you a sense of the layout of the day. So following my remarks, I'm the one standing in the way, we'll have a talk by our first keynote speaker, followed by some amazing rapid-fire talks by postdoctoral scholars in the Institute. We'll have a brief break, then we'll come back for a second keynote address by Dr. Verna Yiu and a fireside chat with Drs. Cook and Yiu, moderated by Dr. Anderson. We'll follow that with a lunch, and we'll have some more postdoctoral scholars presenting their research via posters. So why did we choose the theme of citizen engagement in healthcare. Well, we know that citizens, patients, families, members of the public want more of a say in their health. And we also know that when you engage people in health and healthcare, in research, their outcomes are actually improved. However, both health care delivery and health itself are not equitably distributed among the population, and we are working at the O'Brien Institute to change that. And so the goal of today is to present examples of research and innovation that speak to citizen engagement in health and healthcare. So it's my absolute pleasure to introduce our first speaker. Dr. Deborah Cook is a distinguished professor of medicine in the departments of medicine and health research methods, evidence, and impact at McMaster University. She's the academic chair of critical care medicine at McMaster, and she also holds a CIHR Tier 1 CRC in intensive care medicine. She's a frontline intensivist at St. Joseph's Healthcare in Hamilton, and her studies, as Tom said, have informed practice and guidelines around the world in critical care. She has over 800 peer-reviewed publications and tens of millions of dollars in funding. She is an inspiration to everyone that she meets, particularly those of us who work in critical care and have the pleasure of collaborating with her, with learning from her, and with being mentored by Dr. Cook is truly a pleasure. She is a founding member and chair of the Canadian Critical Care Trials Group, and the Deborah J. Cook Mentorship Award, which Dr. Stelfox has been a member of, was created in recognition of her mentorship to students, trainees, and faculty focused on critical illness. She's a fellow of the Royal Society of Canada. She has won CIHR's Gold Leaf Award for Impact and a Lifetime Achievement Award from the Society of Critical Care Medicine and the American Thoracic Society. For her enduring scientific contributions to the improvement of intensive care worldwide, she was appointed an Officer of the Order of Canada. It is my pleasure to introduce the 2022 winner of the Gairdner Wightman Award, Dr. Deborah Cook.
Good morning, everybody. Thanks for this amazing opportunity. This is my third time coming to Alberta since the new year, 2023, and it tells you how inspiring I find this province for all kinds of reasons, not the least of which is the conglomeration of amazing scientists who work here at the University of Calgary, and University of Alberta, and elsewhere. And it's been fun to think about the story, to tell you about some of the work I've been privileged to be part of, lead, and importantly, collaborate on. That's focused on looking after critically ill patients. And I start with the word humble because I think humility is in short supply in the world of science. And I think humility is a very important foundation for great science and great collaboration. And the story of critical care in Canada, from humble local roots, starting just outside Calgary, to global reach, I hope is somewhat of an inspiration. Welcome to the modern world of critical care medicine. You'll see here somebody, you may not even be able to tell, there's a patient in the middle of this photograph. You can't tell anything about the patient, may not be able to see her or him. But the patient and the patient's family is the reason for everything that I do. The ICU, intensive care unit, is replete with technology, basic and advanced life support, developed and disseminated with great enthusiasm, often far before that same technology has been properly evaluated. The study of clinically based, patient-centered critical care research has not been linear, as many would know from their own work. It's often thought that for research programs that are part of the long game that I reflect on, they may start in the minds of some with ideas, creativity, innovation, inspiration. Preparation obviously is key, and then hard work and perspiration can make it happen. It's much, much more complicated than that. When we first began in critical care, we went to the mountains for our inspiration. And this is the first archival photograph I've been able to locate that represents a meeting in Emerald Lake when I was a fellow at Stanford, invited back by the generous senior male authority figures in critical care at the time, to join discussion about what we might do to try to better understand critical illness and broaden our knowledge of diagnosis and monitoring and prognosis and prevention and therapy. This gentleman in the light blue is Dr. Tom Noseworthy. You may know some other individuals in the pink shirt. These were men who wore vibrant colors. And well, I don't know if you know any of these folks. This is Dan Roberts, but I was looking in the background in awe, just so happy to be part of the scene. We got together across the country to try to understand how we might achieve our ambitious aims. And we recognize the need for increased rigor in research. We know most of our studies were at what we would now call high risk of bias. They were small studies. There's very little collaboration. Obviously, in basic science, there was far less collaboration, but we wanted to share and develop our skills and democratize the way in which we do studies with extreme rigor. So our idea was to create a nurturing venue and enjoy the inimitable Canadian camaraderie, which has characterized much of what we've done over the last 3 decades. And when I started in internal medicine at McMaster, I had the great honor of working with David Sackett and learning from him, the late, great David Sackett. And I know Dr. Eddie Fan remembers our early days of evidence-based practice, evidence-based medicine. Dave was always very energetic and tried to encourage us to work together and have some fun. And Gordon Guyot has always been trying to achieve, and I think achieving this balance of nurturing and yet challenging the people who he has mentored, and I've really benefited greatly for that. But as all of you know, the dyadic relationship of mentor-mentee that people talk about is also perhaps an anachronism now, and there's a much broader way to think about mentorship in science. John Marshall was one of the senior investigators who was very kind to me early on, encouraging me to just spread my wings and speak up in a room when I felt very inhibited. Tom Noseworthy always suggesting that I come along and asking me questions, sometimes just over coffee or a glass of wine. What's next? And then why are you doing that? And okay, and then what? And he really made me think about science and collaboration from a social perspective, which is very important. Maureen Mead is one of the people I had the great privilege of mentoring, but the reciprocity of the mentor-mentee relationship and understanding reverse preceptorship and mentoring has been playing out as one of my most treasured collaborators remains Maureen. The other part of community mentorship I think is important to acknowledge is people who may disagree with you. And this is a photo of Bill Sibbald, a very feisty senior scholar, clinician who spoke up to try to show the world how important it was to understand what we're doing with the sickest patients in the hospital. And he was always a little edgy, but he also had great humility and asked me if I would have coffee with him over the phone in the pre-Zoom days to teach him about evidence-based practice and how to improve science. And I'll never forget that humility of a giant in our field. We got together with the Canadian critical care community to create this mission, and we did not require a multi-million-dollar company to come in, write things on chalkboards, and tell us what we wanted to do. We're keen to advance the care and improve the outcomes of critically ill adults and children through excellence in clinical research, not to negate basic science research, and perhaps before we fully understood the importance of health services research. This was our early mission. And we had values that we found it helpful to write down. Obviously, scientific creativity and integrity, but always clinical relevance. We wanted to maintain not a sense of competition, but collegiality, because that always takes you farther, and be accountable to each other in sharing our work, including the ups and downs, and be responsible to our funding agencies. We talked about organizational culture, which must acknowledge scientists too are social creatures. And in an institution, perhaps here as in the O'Brien Institute and many others, there's an organizational culture which may be invisible. So I think of organizational culture to an institution or a group the way personality might be to an individual. invisible forces that may influence activities, words spoken, the way things are around here. And while there are many different types of organizational culture, we focused on the critical care trials group on development, innovation, being organized and rational, being strategic, but always community building, egalitarian, before that was even part of the lexicon of science, and we really eschewed hierarchy and bureaucracy. And the early chair on the far right, Dr. Tom Todd, is still a thoracic surgeon who also was an unusually humble gentleman who got us all together. And I was so incredibly grateful to be given the opportunity to lead the trials group for a couple of terms as chair. John Marshall from Toronto, Paul Hebert from Ottawa, Rob Fowler from Toronto, and now Kusum Menon, our first pediatric intensivist, chairing our group, and we expanded beyond. Our approach was nonlinear, but recognized the power of discussion. So naturally, creating ideas, being inspired by what we would want to study required for us the connection, the connectivity in person, the idea that metaphorically, if not actually, we would have piece of paper on the board, we'd be writing things down, we'd be debating with each other, discussing widely, and through that discussion developed most of our programs. And I just wanted to give 3 examples to show you. This was our first one on stress ulcer prophylaxis, and it shows the importance of preparation, but so much more than that. So early on in my training, critically ill patients were receiving not 1 but 2 drugs to try to prevent bleeding from the gastrointestinal tract, typically the stomach. And it wasn't very clear why 2 drugs were needed, but historically a lot of people were dying. This bleeding, upper GI bleeding, was frequent, it was often fatal, and people were getting 2 drugs to try to prevent it. It seemed unusual, and I was keen to do a randomized clinical trial to find out, should we have 1 drug, just 2 drugs really, or which drug, and was ready to go with a randomized clinical trial. But we quickly stepped back and realized, no, we can't just launch into a big trial, as is a very popular approach these days. We need some preparatory work. And going ahead to understand what this entity was of upper GI bleeding with a small prognosis and diagnosis study, understanding the risk factors for bleeding, and then doing a meta-analysis to understand the best estimates of the most effective prophylactic drugs was key. And we did these steps together, and our first project for the trials group was in fact based on this, just observing what the heck is upper gastrointestinal bleeding, how often does it occur, what are the risk factors, what happens to these people who get bleeding, does it really matter? And this background work averted several problems before we launched on the randomized clinical trial and helped us have a watertight grant application, which was very successful first time around. And this importance of doing this preparatory work really stuck with us in the trials group, and we've gone on to take that approach ever since. The randomized trial, also published in the New England Journal, like our first paper, basically showed that ranitidine, at the time the commonest acid suppressant agent, was 50% more effective at bleeding prevention. And there's no difference in mortality as expected, but there was a suggestion of ventilator-associated pneumonia. But that wasn't enough. Having received MRC dollars at that point and got our community together to do these 2 big studies, we thought, what else can we learn from the database? Careful not to torture the data from a database, we realized there were many questions that could be addressed by this, and we went on to do additional studies to reaffirm, confirm, or refute risk factors for bleeding and prognosis, understand attributable morbidity, mortality, and then move on to the secondary outcome of pneumonia, which subsequently launched an entire research program by Dr. Darren Hyland, now here in Lethbridge, on ventilator-associated pneumonia. And this helped us understand that at a time when a field is open and there are more questions than answers, which I believe is almost always the case, if you're honest, this was an approach we took, thinking about the long game, long-term research agendas, and knowing there are many questions that people may think we have the answer to, but we actually don't, and we need methodologic attention to detail. And so we felt very good in the expensive intensive care setting to be sure we were a good return on investment early on when we gathered as a new consortium. So we harmonize a little bit differently by trying to always synergize in person, talk often, not to be afraid of disagreeing politely, get energy from each other. And people often talk about introverts, and extroverts are more energized by other people. But in science, I think the energy of communication, ideally in person, is super helpful. And we mobilized as a community to achieve a great deal. The second program I wanted to get into was translating some of our knowledge generation into knowledge translation, and it is focused on blood clots. As probably many of you know, when you're immobilized, when one is immobilized, there's a greater risk of blood clots, typically in the legs with long plane or train travel. But Virchow's triad would indicate hypercoagulability, which is a sine qua non of being critically ill, and vessel wall injury due to all the catheters we place in critically ill patients. This is like a confluence of disasters for the development of thrombosis, an invisible problem to a huge extent during critical illness. So we also realized, looking around the literature and the august bodies putting together practice guidelines, this is a great way to do an environmental scan. We know that patients who've got so much vessel injury, so much of a prothrombotic state, and who are entirely immobilized by sedation or their illness or paralyzed, we saw in these documents, they didn't even mention medical, surgical, critically ill patients. So another cue or clue that this is a great area to investigate is the invisibility of the population of interest in traditional documents. Another great clue came from an observational study that we did, knowing there were two types of heparin to prevent blood clots for hospitalized patients still used: unfractionated heparin, an older, less expensive, highly effective drug, and the newer, more costly, generally believed to be more effective drug, low molecular weight heparin. Both available, 2 countries, same year, totally different practices. You know also, when you see something like this is a hot topic. So we knew environmental scan, practice assessment, this is where we need to go. So we wondered for med-surg patients, excluding those patients who must have low molecular weight heparin, such as trauma victims, a group of people who are excluded. We knew this was a worthwhile approach and went on to conduct a big international randomized trial. And like our previous research, we didn't just launch in quickly. We did even more preparatory work. And after PROTECT, as it was called, was finished, we did even more work thereafter, trying to be sure we learn as much as possible, as I think is ethically mandated when patients are entered into studies through their own consent or from family members agreeing that they may help contribute to the care of future patients, if not for the patients themselves. Finishing up, though, with health services hat on, and with that of a clinician, with that of a trialist, you'll see the results here can be interpreted many different ways for this randomized trial. Our primary outcome was deep vein thrombosis of the leg, diagnosed by compression ultrasonography. And you can see here the hazard ratios and confidence limits are such that it just does not represent a significant reduction associated with low molecular weight heparin. Trend, maybe, if you're into trends, but this wasn't clearly of benefit. Pulmonary embolism, a less frequent event, you can see only 67 such events, a potentially more serious outcome for vulnerable critically ill patients with poor cardiopulmonary reserve. There was a significant reduction with low molecular weight heparin and a 50% estimate overall. Hospital mortality was not anticipated to be lower, and it was not significant. HIT, or heparin-induced thrombocytopenia, potentially fatal drug allergy, which itself is extremely expensive to treat, unless people die quickly, which is an alternative outcome. This was also much less likely, 50%, and there was no difference in bleeding, and everyone was afraid of giving the more potent, expensive drug in the expensive intensive care unit where people are at risk of bleeding. So this was, again, on the one hand, you can say, oh, that's so complicated to interpret. But it was also a perfect storm of outcomes that made us think, well, if you're a trialist, fortunately, there are not too many narrow-minded trialists who just look at the primary outcome and say, okay, that doesn't work, that low molecular weight heparin. But all the outcomes are of interest. Certainly, if you're a patient or a family member, you want to know about all of the bad things that could happen to you, and they're all less likely, slightly less likely to happen, or no difference whatsoever. So from the public's point of view, that could be the case. But what about health services? Health services, we must live in a world where we not only consider the acquisition costs of drugs, but the cost of the consequences of these events. If you die quickly, you don't cost much money. If you live longer and have complications, there are more healthcare resources consumed. So we thought about a parallel economic evaluation, and Rob Fowler from Toronto was very helpful in bringing this up through our coffee conversations. Another example of something I don't think I would have embarked on my own without these discussions with him. And the outcome in the first bullet I showed you, the acquisition cost for this low molecular weight heparin drug is greater, but because the consequences of some of these serious events did consume a lot of healthcare resources, we were able to determine that for a modest size intensive care unit, only 15 beds, if people were using a less expensive and standard unfractionated heparin, they switched over to low molecular weight heparin, there'd be $1 million, quotes, cost saving. And that caught people's attention. We had planned many more studies to evaluate this, and I had the great fortune to meet and discuss in more detail with Tom Stelfox, who has been leading the best work in Canada in critical care. He and colleagues trying to understand our choices in practice, the impact that these choices have, not only on patient family-centered outcomes, but on healthcare resources, and think more carefully about adoption consequences and interventions we might consider for de-adoption. And I've really been privileged to discuss and work with you on some of that activity, Tom. I'm going to move to the third program now to talk about dying. And we can't live in a world today without, post-pandemic world anyway, as Tom alluded to, without understanding the importance of better caring for patients with best evidence who have COVID and those who do not have COVID. In Canada, as you know, most people die institutionalized in some manner, technologically supported, sometimes with care concordant with their values, often not, unfortunately. Data from a decade ago would suggest, if safe, if possible, affordable, Canadians would prefer to die at home, whatever home looks like, with their family, however their chosen family is viewed. That is not the case right now. And as we know, all of the technology used for critical illness can help save lives. We always like to say it delays death. And the idea that a good death is a basic human right, according to the World Health Organization, that is a fantasy for most people around the world. And we can do better in Canada, not necessarily in the ICU. But I was interested in this research program for a long while. And I remember talking to one of the senior folks at McMaster who I was sort of having a career review, and I was thinking about doing some research on end-of-life care, and he was saying it was really soft science, and it's not really a great topic for a serious investigator like you. You know, maybe stick with some of your other activities. And this notion of technology, its advance was really not challenged or questioned even. And there are lots and lots of gaps in our understanding of how people die during critical illness. And the care of people in ICU obviously is not like a doctor and a nurse and the patient. There's so many professionals who are involved in the care of patients who live and patients who die, looking after the drugs, the pharmacists, the respiratory therapists, the physiotherapists, the occupational therapists, spiritual care clinicians, social workers, all of these people around every single day for patients who are dying. And we talk about people who are dying, because we're all dying here today. It's a question, though, in ICU of how much sooner is that going to occur? And we put some of these studies on the back burner for a long while, but I wanted to tell you about one very simple study that was an observational study in the early days where we enrolled in several centers, mechanically ventilated cohort of patients. And they were all on the ventilator, which is the quintessential life support technology, the breathing machine. And when people live, we wean the ventilator. People breathe on their own and hopefully live, but obviously some die. Some people die on the ventilator, whether or not they have a cardiac arrest, they just can't get off. And other people have withdrawal of ventilation in anticipation that they will death in a more planned or orchestrated way, particularly when the outcome for that patient and the care being administered to that patient is discordant with what we learned from the families they would want if they could speak for themselves. So this is a simple flow diagram of what happened. So for ventilator weaning, you expect most of these people to live. In fact, only 90% do. For those people who die on the ventilator, that's the end point right there. But there are some people who have ventilator withdrawal in anticipation of death, but actually they don't all die. And some of these people went home. So this was a bit of a concerning piece of data. And I think, again, caught people's attention because of the confidence in the community about we know how to handle people who die, it happens, we try to take care of them. And this was a particular study funded by the Ontario government. We applied for a $400,000 grant, and they said, okay, your grant is awarded, but we could only offer $40,000. And so I remember calling the Ministry of Health at that time, people who answered the phone at that time, you probably remember those days. And I said, I'm just wondering, there was a zero missing on this grant. It was awarded very highly, but it just did not achieve stature, and the scientific topic was devalued. So that wasn't too surprising, having been around the block, but we did proceed, and a lot of people actually participated in this study without any funding, including Americans who always want your firstborn child if they're going to do anything for less money, and colleagues in several other countries in Sweden and Australia. We went on to try to understand what are the determinants of withdrawal of life support, because our community always thought it's just people who are really sick, they're really old, those are the people more likely to die. But what we found through regression analyses is those people mechanically ventilated who are also on an advanced life support of inotropes, they're more likely to die. Then there's the phenomena of patients whose physicians think they've got a less than 10% probability of living. And then there's the, again, physicians' largely prediction that their brain isn't going to be very good, that is a predictor of death, and then the perception that the team has that the patients wouldn't actually want this life support. So it was not the traditional biomedical factors that were the determinant of death, but it was all these socially constructed, dialogue-based, value-laden determinants of death. And we further went on through surveying people real time as care was being ministered without Research Ethics Board approval at that time, because people thought, don't worry about that. No, that's not really scientific. So we handed out a survey every day to the medical student, the resident, the bedside nurse, the attending, about the care of these people on the ventilator. And there was often some discomfort, as there still is today, about what's happening to these patients. And we asked people when they were uncomfortable, and they said, we're uncomfortable because this is too technologically intense for this patient. We asked them to list the reasons why, and this was a place where it gave voice to the fallacy or the fantasy of people's predictions, which is an important humility factor for a lot of clinicians in the ICU. The use of resources inappropriately, not because of the cost, necessarily only, but the cost relative to the values of the patients, and overestimates, etc. So it was a very interesting program, and in addition to having a number of academic products, it also helped to engage and democratize science for the bedside staff, and was one of the first areas in critical care where the clinicians contributed to the research more proactively. We had one family member in the early days advising us without being called a formal family advisor in the way that Dr. Feist would approve, but someone informally helping us to look at this area, and we self-funded a lot of it. And it helped to legitimize end-of-life research. It was something that, especially in the US, many people went on to make that their entire NIH-funded career. That would not have happened in Canada, but I do think Canada contributed to some of this work through the open-minded collaboration of many people. So this was always a favorite passion in my practice, end-of-life care, a favorite focus of my teaching. It was like sort of my B game, if you will, in science. I always loved it, but I had to be patient because it was not ever mainstream enough, but we persevered and kept going, and I think made a big contribution with some landmark and controversial studies, which really, again, legitimized, democratized, and destigmatized the idea of critical care scientists studying dying. Enter COVID, a nightmare for everybody. End-of-life care front and center, newspapers. I'm sure everyone in this room knows people who have been critically ill with COVID, possibly passed away with COVID. And the silent majority of people who died during the pandemic who did not have COVID and were cared for like this. Clinicians looking like aliens, people dying without their family members at the bedside. This is a time when technology obviously helped us. The therapeutic interventions that Tom alluded to, studied so rapidly and efficiently that Canada contributed to these trials for sure. This was a place where I was worried about humanism taking a big hit, and where we wanted to help ensure dignity-conserving care. And there was an end-of-life project that began, again, it's just part of my practice, to try to improve or enhance the dying process, honoring the inherent dignity of all patients, and to try to help give families a sense of agency to do something and support them in their grief, and for clinicians to inspire a deeper sense of our vocation. How would this be possible to do anything in the pandemic? We were able, in institutions engaged in the Three Wishes project, to continue to elicit, often by video conferencing or by telephone, implementing personalized wishes for these patients and their family members, often as sort of acting, if you will, as surrogates. And wishes take so many forms: humanizing the environment. Music plays a very important role. Creating keepsakes for people to take home. Reconceptualizing organ donation as a way forward. And this project has helped us understand that honoring patient dignity is not only possible, it is imperative. Giving the voice to family to do something, tell us about the individual who's dying, and calling forth clinician compassion. Again, in science, an atypical concept. So we learned during the pandemic that clinicians can and were inspired to learn about each patient's story. Everybody has a story. Everybody has many stories. Filling the gap of family members, and we were so relieved that in the pandemic we were indeed able to help people and more intentionally preserve compassionate end-of-life care. So what is a wish, you would say? Are we even talking about science still? Please open your mind to qualitative work, interpretation, concepts, constructs. What have we learned from interviewing, not patients, they died, family members and many, many clinicians in many centers all over North America, albeit only those who we can understand in English, tragically, but we're working on more cultural competence and trying to be more linguistically diverse in our work at the moment. This notion of eliciting a wish and trying to implement something that would bring comfort at the end of life is an important way to recognize the patient, that patient that I showed you who you could not see in both of my images, a therapeutic connection, a way to express our humanity for families to see we too at the bedside, we too as scientists are human being, and a tangible expression of compassion. So what we've seen over the pandemic, in some centers anyway, humanism is alive and well. We've been able to retain dignity-conserving care. My last message to you about science and this incredible journey. Is to make sure you celebrate. I've always tried to think that my best work is ahead of me. And I hope as scientists we remember our shared humanity, but also to acknowledge the hard work we do, but try to come together and believe our best work has got to be ahead of us, to stay humble and make a difference. Thanks.
Thank you so much, Dr. Cook, for that absolutely incredible talk. We now have time for some questions for Deborah. So we have some microphones set up in the pathway there. And so, Deborah, can we use this microphone, Angie? Yes. I'm going to pass you a microphone, Deborah. Okay, hello, yeah, good, okay. So while you all are thinking of your questions for Deborah, I'm going to start. So obviously, Deborah, the theme today, citizen engagement in health research and healthcare. Maybe you can speak specifically to the impact that these individuals have had on your research program, how you've conducted research and what you've learned from them.
Well, Kristen, I think you're the expert on patient and family engagement, public engagement, and scientists here in Alberta know much more than I do and have lived experience as such. The greatest patient engagement, family engagement work that I've done has been on the end-of-life care program, as you might imagine. And their voice has really inspired us to keep going. And the interview data that we've obtained and reflected on has helped to change this 3 Wishes program, which was a way of practice, then it was a demonstration project, then it was a pilot project, then it was a multi-center formative evaluation, 3 papers in the Annals of Internal Medicine, which I say not to brag about, but to say these were recognized as interventions that can make a difference and deserve scientific scrutiny, if you will. And it would not have been something that I pursued as rigorously without the voice of the family members who told us how important it was. And so it was incredibly motivating to learn from them, and they've inspired us hugely to keep going. So in this sense, this program of work is completely transformed and would not have been realized without the engagement that you and others have been spearheading. I would have been kept doing the trials and the observational studies.
Thank you, Deborah. So we have time for questions for the audience. Don't be shy. You have a Gairdner Award winner here. So Lori's gonna pop to the mic.
Thank you, such an inspiring talk. You mentioned about engaging non-English speaking patient and family participants, and I also think sort of along the same lines of those from areas of lower socioeconomic privations, et cetera. And I just wondered, moving forward, and especially from a public health lens, what your thoughts are on how to better engage those harder to engage partners.
Thanks for the question. Our work now on the frontier is addressing this gap in the research program, and when I finish the current trial, I'm doing that's sort of my next area of attention. So safety net hospitals in the US, there's a big NIH grant under review to focus exactly on that, actually exclusively on that particular population. We have some work going on in Thunder Bay with a grant, and in Brantford in Ontario, focused on Indigenous communities. And many of our wishes, we've always characterized them as being spiritually sensitive, culturally aligned. I know people thought when we started this program of work, it would be about readings, rituals, prayers, and that is a very, important religious lens, but spirituality is so much broader than that. And we've learned about the importance of getting outside, of uplifting music, of culturally concordant activities that we never would have done before, people with all kinds of backgrounds. Our interviewing skills, and I see Carla here has helped us so much with some of our patient-important bleeding work as on a different topic. Our linguistic skills are not as great, and we haven't ventured in any of the work I've done with translator-enhanced interviews at this time. But obviously that's hugely important. Thanks.
Thank you. Dr. Noseworthy.
Deborah, thanks for like 30 years of brilliance and doing it with having fun. CHR has put a lot of money into patient engagement. In my view, we're not reaching the levels of capability, quality, and attainment that England and NHS has. What would you do? What couple of things would you do to strengthen the SPORE program in Canada?
I don't profess to have any insights that you and others wouldn't on that front. I know there already is extensive patient and family engagement in the PACER program here I'm very aware of. I don't know about the SPORE program, but I'm wondering if it became an obligation for all grants awarded by CHR and some of the other larger provincial agencies, if there wouldn't be a mandate before a grant would be considered to itemize some meaningful engagement of patients and families on planning committees, steering committees as active partners. There's a lot of tokenism that I see. So someone is on a data monitoring committee for a trial. I mean, I don't know. There's a lot of tokenism. We're getting there, baby steps. But I think the mandate for more meaningful engagement and input from those expert in the A to Z methods by which patients and families could meaningfully engage and avoid tokenism, more of those people advising granting agencies and frankly teaching the investigators about that could be important. And I'm not sure how much will change without it being an obligation. Not saying the non-obligation is the best way forward, but it does tend to get people's attention.
Dr. Santana?
Hi, Deborah. Thank you very much for your presentation. Very inspiring. I love that you brought the humanity aspect of the ICU unit and the struggles that happened during this day. I have a question for you. You're talking about engaging the families in the ICU through this really hard time that we just went through. And do you have a sense of evaluating the engagement? So you brought the family voices to the care to try to improve the care and make decisions that were informed by them as well as evidence-based. What are your views about how to measure that level of engagement, the evaluation of it?
I think that's ripe for an instrument to be developed about patient engagement from the perspective of those whose engagement we seek. So if I were starting out and focusing on this kind of area, I do think that's meritorious because of the prevalent tokenism and honestly people still learning what it means to involve patients and families. I think it is a fantasy to believe if you don't measure it, it doesn't exist, or if it's some things are too hard to measure. Yes, but I'm wondering if a multidimensional instrument could be developed to help measure that kind of thing. Frank feedback through dialogue would be really important, and debriefing. I know there are people who are engaged currently in randomized trials in our country outside critical care. And it would be great to have exit interviews and proper analyses also about what they experienced and what they would suggest so that the ideas going forward for improvement came from them. And I think we could do more in that regard, and it would be very fruitful, especially across disciplines, and it could be very different for chronic illnesses or hospital-based conditions, and obviously for different topics. So That could be a good request for proposal kind of idea.
Yeah,
Maybe
we
you
have
had that in mind, did you?
Yeah, I think that we have a toolbox, and you are a McMaster, so you probably know Julia Abelson. So she has developed a toolbox, but it's very specific to measuring the engagement through the patient-oriented research, rather than the engagement that you're talking about, right, at the level of clinical care. So, yeah.
Well, I think you raise a great point about Julia Abelson, who I know well from McMaster. I just see her every 5 years now, but I have been closer to her at a time. But there are probably things going on in our own backyard. Like you just mentioned, Julia, I remember she did that work on public policy and engagement of members of the public, and could learn a lot from her. Back to one of my sort of principles of talking, pausing, and listening more. Thank you for that reminder.
You so much.
Dr. Hill?
Deb, thanks very much. Michael Hill from Neurology. I wanted to ask you an ICU question in a way, right? So like you, I deal with a lot of patients who lack capacity. And I wondered about your approaches or strategies you've used, because to my way of thinking, the family is essentially the surrogate for understanding what the patient might want. And of course, there's biases introduced, right? Family relationships, and if the patient dies, you don't get to ask the patient if they said the family made the right decision, right? If the patient lives, then the patient's biased by them by surviving. And how have you, thought about this problem of engaging people who are fundamentally proxies to what the patient might want?
It's a bedeviling problem and incredibly complex and important, and I'm sure you know it well. No easy answers, but our approach in the ICU often is to take a serial conversation view, and it's not one question, then you understand what's going on, but the therapeutic relationships are so important in the ICU when we're really out of the comfort of a office or a visit where the conversations may be more relaxed. So we do it over many days. We do it interprofessionally and really depend on bedside nurses who are spending the minute-to-minute bedside intimate care with patients and family members there, elicit their input. And when we have meetings, the States, they often call it the family conference, which is such a sort of objectifying notion to me, but we do it over time with multiple people and try to also appreciate that it's not a one and done conversation, and appreciate the assistance of spiritual care clinicians, social workers, nurses. Some people tell everything to a nurse. They won't speak to a physician much. Some people spill their heart out to a spiritual care clinician and just basically not want to talk to us. So this, the idea of, I think, putting a doctor hat on, I try to diagnose the situation and what's really happening here, and try to take it slow and be sensitive and imagine being on the other side.
Dr. Day?
Thank you, Dr. Cook, for an amazing talk. I'm wondering, in your work, when you took on the soft science, according to your predecessors, was there a role for social scientists on your team in legitimizing the work to the funding agencies or picking the right outcomes, that kind of thing?
Very much so. It was one of the greatest aspects of my career where I feel I learned the most, because I think if it's a great gift to feel like you're always learning. And the social scientists who've helped me be anthropologist, Dennis Wilms, Mita Giacomini, absolutely brilliant individual, just retired, and Meredith Vanstone, who I'm so privileged to collaborate with Kristen and with Carla and colleagues here. So the social scientists have been incredibly important, and they've taught me it's not just everyone's got their own take on something, but the importance of a shared view and how we learn from each other to try to have similar lenses with different backgrounds coming to bear on a topic. So that's been hugely important, yes.
We'll go up to you, sir.
Yeah. So the NIH in the States has put tens of millions of dollars into the Mayo and 10 other major academic centers for personalized medicine, looking at how patients' P450 enzymes metabolized medicines. Canada's very multicultural. Do you know if the American ICUs and yourself have to adjust to patients' ethnicity, particularly if their parents are from very different ethnic groups and they metabolize medicines in different ways? Does this affect the medicines you use?
So you're asking if personalized medicine based on sort of genetic epidemiology that may be ethnically based, whether it bears on the science we do in the intensive care. It does in some settings, some sectors, a lot of it on pharmacokinetics, drug metabolism, yes. I'd say not as much as some other fields of medicine, but there is attention to it. I don't know, I would say mostly in the drug area. Would you agree, Tom? Maybe more to go there, too.
Dr. Marlett?
Hi, what a wonderful talk. I was involved in the early stages of PACER, and I'm recently really involved in looking at the science behind how we can effectively really recognize the roles of patients in their own care. But what I'm really interested in right now is the dramatic movements internationally to democratize science. And I think it's really important that we look to those people who are looking at the links between research and innovation as the hotbed for why we need to include particularly patients, but also those from the communities that they come from. And I'm just wondering if at McMaster, because I know you're involved right now in training a PACER group, so that link is starting to happen. How has that need to democratize science and to be responsible in the innovation that comes from science? Is that connectivity and the linkages happening in Canada? Because I see us being way behind in our understanding of what democratizing science really why it's so essential.
It sounds to me that you've thought more about it than have I. I appreciate your comments very much. I wouldn't know if Canada's behind or not, but I am a very big believer in democratizing science, and my personal activity has been at the bedside, doing that by engaging pharmacists and nurses and respiratory therapists in research, facilitating the leadership of science, democratizing the process to help people who are social workers and spiritual care clinicians develop their own research questions, get grants, and help them implement. So I've been very, very active in encouraging and supporting and ensuring those opportunities exist. But there are many, many domains of consideration, as you've alluded to. I'm just speaking about where I have tried to play a role, but more work ahead needed, I'm sure.
I think you are democratizing science. And I'd really hope that one of the things that you can do, and within our whole zeitgeist almost, is to take what's happening at the bedside and push that up to the policymakers. And so they become more engaged in this whole process. So thank you.
Thank you. Dr. Harali?
Hi, thank you for the great talk. It was very inspiring to hear. As a young woman in this field, what advice do you have for women in critical care? We often see that in the critical care environment, there's like a 30% representation of women. How do we address that gap to be more representative of the Canadian population? And I forget my other question. Yeah.
It's a long possible a series of comments I could make, and I think the work of Jenna Parsons-Lee and Kirsten Feist and so many others here have, your work has shone a light on this issue and offered many, many solutions for consideration. But as always, we try to change the world and make a difference as much as we can in our own backyard with some sort of micro-level approaches and maybe larger systems approaches as we're able. I've always encouraged women to find and fuel their passion. Understand that it's not for anybody an easy road to be a scientist. Find comrades, embrace the challenges along the way and learn and grow from them. And just keep going forward. There's, I hope, a chance for us to talk more personally about some of my detailed strategies, but there's a fair bit written about this in the literature already, and I'm sure you got your own strategies you share with others, but it's up to us to make a difference. You too.
Thank you.
Go ahead.
Hi, Dr. Cook. Thank you so much. My name is Yang. I'm a postdoctoral scholar in CHS right now. Hi. I really appreciate the nod you've given to qualitative research and to social scientists as an interdisciplinary researcher myself. That is really great to hear. Thank you so much for sharing your successes and your stories about patience and perseverance. I think we all have a few. I'm wondering, what are some of the current projects that you're working on? What are some of the questions that are keeping you up at night?
And the main thing I'm working on is finishing up a randomized trial I'm privileged to collaborate on with Tom and Kristen and Daniel and Niven and others here. We're reevaluating that very first topic that I mentioned about the bleeding from the stomach and how we might best prevent gastrointestinal bleeding, because some of our early work had turned into practice guidelines so that everyone gets acid suppression. And that's being reevaluated now because of concerns about possible side effects of C. diff and Clostridium difficile pneumonia, increased risk of death, and some of the later research. And it's one of the other great stories about humility, because we thought, okay, we sort of figured that out after so many projects in that field, but we're revisiting it, and that is very much aligned with the Declaration of Helsinki, that scientists are need to ethically reevaluate that which we think is true to make sure that it is valid, it does represent current best evidence, and it is available to all and stands the test of time. So that's one of the interesting stories about things I'm working on now. And with the Three Wishes project, just trying to encourage others to take the lead, embracing more of the social scientists' qualitative research methods, and focusing on some of the gaps your colleague alluded to earlier, so that the approach to compassion end-of-life care is available to as many individuals as possible in the ICU. And we're taking this out to hospices and collaborating with pediatricians, who are always a little more ahead of the game when it comes to patient family-centered deaths, of course. So just sort of turned into a movement. I'm supporting, not leading, I'm just supporting.
And the last question, Dr. Tui.
Thanks very much. Dr. Cook, I just can't say enough about your humanity, your humility, and your impact. It's really resonated. And I just wondered if you would be able to reflect a little bit, especially the pandemic and the early days of the pandemic really shone light on ageism in issues around, how to disperse medical resources and such. And I think there's a lot to consider around older age in the critical care context, in your Three Wishes programs, in your conversations with family and clinicians. And would you mind reflecting a little bit on how patients of older age fit into all of your work? Thank you.
Yes, thank you, Liz. Ageism is alive and well. Ageism was at play very much in the triage discussions. As we know, age does not reflect biology. The whole notion of frailty not mapping directly onto age, and the Canadian Frailty Network, of which Tom Noseworthy is playing a key role. I think some of the initiatives here in Canada have helped us attend to the problem of ageism, and many of us in the ICU here in Canada recognize that with the number of beds according to our population that we have versus other countries, like even in the UK, there's that is invoked less often when it comes to people being admitted to the ICU.
So I think awareness, like so many problems in life, awareness is key. Using the words, labeling it, and the personal advocacy that many of us are engaged in the critical care setting helps to maintain it's part of the conversation, and we don't just say, oh, that's, oh. And we try in our trials, for example, to be sure we offer the opportunity for research for older people. A lot of times they have been excluded. And awareness in general, but I don't think that's as much of a problem in Canada, based on my travels to many, many other countries. It's not as much of a problem. Not to say we have no trouble with it, but like any important issue that's debated, I think we need to give it a voice. So for example, if I'm seeing a comment and someone is talking about the skies or whatever, I say, hey, let's not be ageist now. What's happening with this fellow? And and we all can play a role, whether it's clinically, whether it's in our research, whether it's in our conversation at policy levels, to try to be sure we're aware of it, we attend to it, we combat it where we can, and advocate, because there's so many isms in science to attend to, but that's important, especially clinically, I think.
Thank you so much. So everyone join me in thanking Dr. Cook. I'm now going to introduce the person who's moderating our next session. Dr. Kara Soro is an assistant professor in the departments of community health sciences, surgery, and oncology, and she's going to be moderating our postdoc session. Welcome, Dr. Soro.
Thank you, Dr. Cook, for such an inspiring talk. That was amazing. So I'm very pleased to have been invited to moderate this session and to hear the amazing work of the postdoctoral scholars here in the Cummings School of Medicine. So postdoctoral scholars are a vital component to the academy. They are highly trained academics, and as such are highly productive and contribute to generating really important research that changes health and health care. They are also key educators in our faculty, as you'll hear a few of ours are. They train our trainees, but I think they also train us a little bit. They push us to learn new things and keep us on our toes and keep an open mind in terms of research. But the time when people are doing a postdoctoral fellowship can be a bit odd. We don't have cohorts like we do in graduate school, so we don't have those peers to lean on. It's a high-stress time. You're looking for those very odd, or those very rare jobs that actually do come up. And let's be honest, the salaries can be a little bit depressing. So I'm really happy that the O'Brien Institute has started a postdoctoral scholar association, and we're highlighting the amazing work that our postdoctoral scholars are doing in such a great venue like the Gairdner. So the logistics. We have 3 rapid fire talks today, and they're each going to have 5 minutes, and then there's opportunities for discussion or for questions. But I also want to note that there will also be some amazing work displayed as posters during the networking lunch, so make sure that you check out those as well. All right, so our first speaker is Dr. Jesselyn Holodinsky. She's a postdoctoral fellow in the Department of Clinical Neurosciences under the supervision of Drs. Michael Hill and Tyler Williamson. Her work focuses on stroke epidemiology, especially disparities in stroke outcomes, access to advanced stroke treatments, and how we can prevent stroke. So Dr. Holodinsky is going to talk to us today about flu vaccination and the association with stroke.
Thank you so much for the introduction. I'm here to talk to you today about influenza vaccination and reduction in stroke risk. We know that recent infection is associated with increased risk of stroke, and also influenza vaccination has been shown to reduce risk of myocardial infarction. So given the relationship between MI and stroke, we sought to answer the question, are individuals with recent exposure to influenza vaccination, we define this as a 182-day period, at a reduced risk of any stroke? We answered this question using population-level data from Alberta from the dates of September 30th, 2009 through to December 31st, 2018. The outcome of interest, again, was stroke events. Our exposures were influenza vaccinations, and specifically the 182-day window following a vaccination. And we looked at several covariates, including age, sex, rural and urban home location, income quintile, and several clinical comorbidities of these patients. Adjusted hazard ratios were estimated using Anderson-Gill-Cox models to account for the time-varying nature of our exposure. I have a little figure on the screen here to explain to you the time-varying nature of the exposure. This is an example of one of the individuals in the study who you can see had 2 influenza vaccination events, and then they have 2 182-day exposure periods following those events. They're shown to you in the blue bars on the screen. Any time outside of that window would be considered unexposed time in our study. We were very fortunate to have data from over 4 million adults across this 10-year time span in Alberta, and that's over 29 million person-years of follow-up, so there was a plethora of data to work with here. I have a few baseline characteristics of the patients shown to you stratified by having ever or never received an influenza vaccination across the time period. And what I'd like to point out to you about the patients is that individuals who did receive at least 1 vaccination across the time period were older, more likely to be female, and had higher rates of comorbidities than individuals who were never vaccinated. The crude incidence of stroke was also higher among individuals who had received a vaccination across this time span, 1.25% compared with about 0.5%. However, in adjusted analyses, considering our covariates and that 182-day window, vaccination was associated with a significantly reduced hazard of stroke following the vaccination event in that 182-day time window. The magnitude of the hazard ratio was quite large, our hazard ratio 0.775. I also have for you on screen here the hazard ratios broken down by stroke type, so we can see that this protective effect did exist across all types of stroke, perhaps a little bit smaller magnitude of effect for those with a transient ischemic attack. Very interestingly, we observed significant effect modification by all covariates in our study with the exception of home location. The general trend was that vaccination was protective across all strata, however, more so in those with traditional risk factors for stroke. A notable exception I'll point out to you here is that for hypertension, where we find that the individuals who were not hypertensive seem to be at a mild increased hazard of stroke, and I'll discuss this a little bit further. Here I have a figure showing you the baseline relative hazard of stroke stratified by hypertension status here. And what we can see is that the absolute increase in hazard in the non-hypertension group was quite small. We were dealing with incredible precision in this study with over 29 million person-years of follow-up. So it's unclear to us right now if this small absolute increase in hazard, which does produce a relative increase hazard ratio, is actually clinically relevant. This is an area of future study for us here. Alternatively, is it possible that this non-hypertension group is sicker than we realize and therefore may be seeking out vaccinations? Could vaccination be acting as a latent variable here, identifying some underlying illness that we haven't had the opportunity to study yet? So what we've shown is a clear and relevant association between influenza vaccination and reduced hazard of stroke. This association persisted across all stroke types, ages, and by varying risk groups. We were able to do this using full population level data from our province out of a single payer healthcare system, and over 10 influenza vaccination campaigns were captured. However, we cannot disentangle the biological effect of the vaccine from the act of getting vaccinated. So what we don't know is, do individuals who seek out seasonal influenza vaccinations perhaps have higher health literacy than those who don't, and an inherently reduced stroke risk to start with? Meaning, could these results be somewhat due to confounding by indication? So what's next for us is to explore just that. We currently have a CIHR-funded project looking at reproducing this finding using more advanced methods of confounder control, perhaps restricting to individuals who seek out other types of vaccinations or using self-controlled case series methodologies. And if we can reproduce this result, would this extend to other respiratory vaccinations? We know things like COVID-19 and pneumonia are also heavily related to stroke. And so is this something that can be reproduced for other vaccinations? And then looking even further into the future, from a population standpoint, we're curious what the impact would be in enhancing influenza vaccination uptake across our province on stroke incidence. Perhaps is increasing vaccination uptake a viable public health strategy, a cost-effective public health strategy for primary or secondary prevention of stroke? I'd really like to thank you for the invitation to be here today and everybody for joining. I'd encourage you to read more about our study. The full publication's available in the Lancet Public Health. Large thank you to my co-authors and supervisors who are here today, and I would also like to acknowledge that this work was performed with the late Larry Svensson, who we had the privilege of working with. Thank you.
Do you think that it would be a more effective strategy for public health to tell people that getting an influenza vaccine would prevent stroke rather than prevent influenza?
It's a brilliant question, and we have a lot of interesting ideas about that. We were fortunate that this study was published in November of this year, so we were able to get some really good media attention around it right in the middle of the influenza vaccination campaign. But we are working with our colleagues at AHS through the next influenza vaccination campaign to look at some of the targeted messaging that we can put out for this. And we also have some patient advisors working with us on what style of targeted messaging might influence individuals to receive an influenza vaccination, and perhaps exactly that if people are maybe more worried about their vascular health than the flu.
Thank you for the presentation. It was fabulous. So my question to you is about pediatrics and the extension to children. Was there any ability to be able to look into the pediatric age group?
Yeah, so we do have the same style of data available to us right now in the pediatric population, and we have some analyses ongoing in this cohort right now, so I don't have any results yet to report, but something that we do notice is in the pediatric age group, the event rates of stroke are quite low, so we're not sure exactly what our results will look like there. And then also, as we look at some of the more serious incidents that happen in the pediatric population, many of them happen in the first 6 months of life, which is also a time point that you're not yet eligible to receive influenza vaccination. So unclear as of now, but a future work for us.
Congratulations. I wondered whether the propensity-matched approach could be done on this very same database to see if there's some internal inconsistency, in your findings, given you know the data so very well, rather than wait for an entirely new database to be generated.
Yes, absolutely. So that is on, we have a kind of a serial list of methodologies we've slowly been building out of how could we interrogate this data perhaps in a more rigorous way, and propensity matching is definitely on that list there.
Okay, and just last question up there.
John Conley, Department of Medicine. Just interested, thank you for mentioning about the issue of health-seeking behavior versus the actual act of the influenza immunization. As an infectious disease physician, we've seen cerebrovascular events after many viral infections. I mean, West Nile neuroinvasive disease is a classic. Every summer we would see it. So there's a whole host of viral infections that are associated. The question I wanted to ask is whether there would be a difference with respect to the types of vaccines used, because we have inactivated a trivalent vaccine, which is egg-based. Now we've got the high-dose antigen quadrivalent, the nasal spray live attenuated. So is there a difference with respect to the immunogenic responses that would be associated with higher immunogenicity vaccines than what you currently were looking at, which was probably the inactivated trivalent vaccine?
Yeah, so this is a fantastic question. In the data that we had right now, we just looked at the status of being vaccinated or not, but we are working with some of our colleagues in the pharmaceutical industry moving forward at looking at different high versus low dose and different modes of receiving influenza vaccination. So that's a future project for us.
Okay, thank you. Thank you. Awesome. Thank you so much, Dr. Holodinsky. Talk about impressive work, and also just want to highlight the incredible teaching commitment that Dr. Holodinsky has in the faculty as well. She teaches 3 core courses. That's more than I do. Our next speaker is Dr. Faizan Khan. He's a postdoctoral scholar at the University of Calgary and Alberta Health Services through the CIHR Health System Impact Fellowship. So he's going to talk to us today about the benefits, harms, and cost effectiveness of indefinite anticoagulation for unprovoked VTE.
All right, so good morning, everyone, and thank you, Kara, for the introduction. My name is Faizan. I'm a postdoc here with Dr. Stelfox and Dr. Feist. And the objective of my presentation today is to use the example of indefinite anticoagulation for patients with unprovoked venous thrombosis to demonstrate how the application or use of mathematical modeling can help address gaps between published evidence from randomized controlled trials and the evidence needed to develop clinical practice guidelines. So as many of you may know, anticoagulants or blood thinners are the cornerstone of treatment for patients with venous thromboembolism or VTE, which are blood clots in the leg veins and blood clots in the lungs. And anticoagulant treatment should be continued for at least 3 to 6 months. Thereafter, a decision needs to be made to either discontinue anticoagulants or continue them indefinitely. And this decision is considered the most challenging for patients who've suffered or experienced a first episode of unprovoked VTE. So that's VTE that occurs spontaneously in the absence of any major provoking risk factors. And so current clinical practice guidelines from the relevant professional societies and organizations suggest or recommend that we continue anticoagulation indefinitely in the majority of patients with a first unprovoked VTE. Yet the benefits or the trade-offs between the benefits, which is reduction in recurrent VTE, the harms, which are the increase in major bleeding, and the costs associated with indefinite treatment have not been formally assessed. Now, while a randomized controlled trial would be the optimal study designed to examine these benefit-harm trade-offs and provide evidence for or against indefinite anticoagulation, such a trial is unlikely to ever be conducted because of the lifelong until death follow-up, as well as the extremely large sample size that would be required. And so alternatively, in the absence of evidence from such a trial, we can use decision analysis or mathematical modeling to estimate the projected long-term differences in mortality from recurrent VTE or major bleeding if treatment is discontinued, and mortality from recurrent VTE and major bleeding if anticoagulation is continued. And so to ensure that there is solid published evidence available to inform our mathematical model, we first synthesized contemporary and reliable estimates for important parameters that are listed in each of the 4 boxes that can help us measure the benefit-harm trade-offs of indefinite anticoagulation. So very briefly, we first published, so here's 2 systematic reviews that we published to establish the long-term risks as well as the case fatality rates of recurrent VTE and major bleeding up to 10 years after discontinuing anticoagulation. And then here's a set of systematic reviews we conducted to establish the long-term risks as well as the case fatality rates of recurrent VTE and major bleeding during extended or long-term anticoagulation up to 5 years. And so then, using best available evidence from the literature, we constructed a mathematical model to simulate lifetime outcomes for 2 hypothetical cohorts of patients, one cohort assigned to discontinue anticoagulation and another cohort assigned to continue anticoagulation indefinitely. And the outcomes of interest were recurrent VTE, major bleeding, costs in Canadian dollars, as well as quality-adjusted life years, or QALYs. So here are the results, and I'm showing you the incremental difference in outcomes with indefinite anticoagulation as compared to discontinuing treatment. And what we found is that for the average patient with a first unprovoked VTE who's completed 3 to 6 months of initial treatment, continuing anticoagulation indefinitely is unlikely to provide an additional mortality benefit given a very low probability of improving life expectancy. And so this sort of highlights that the uncertainty in the net mortality benefit of indefinite anticoagulation in all patients with a first unprovoked VTE appears to be much greater than currently emphasized in published guidelines. Moreover, with increased costs to the health systems and no clear net gain in quality-adjusted life years, we found that indefinite anticoagulation was unlikely to ever be cost-effective. My two takeaways are that models can extend beyond published studies to help us evaluate key or important benefits, harms, and costs of treatment strategies over a lifelong of a population. And where there's critical gaps in evidence between primary studies and the questions that guideline developers hope to address, model results have a place just besides findings from systematic reviews to inform healthcare policy and patient care. I'm very thankful to the support of my PhD work from CIHR as well as my co-authors, and I'm also very, very happy to share that our study is now provisionally accepted for publication in Annals of Internal Medicine. Thank you so much.
Congratulations.
Thank you so
excellent
much.
work. So my question is about what other types of clinical practices do you see this type of mathematical modeling be useful for?
Actually, when I was planning my PhD studies, we looked at some of the other clinical areas where decision analysis and mathematical modeling has been used. Dr. Deborah Cook has used it to do cost-effectiveness analysis of low molecular heparin for thromboprophylaxis. A recent example from Calgary was in left atrial appendage closure in patients versus anticoagulation in patients with atrial fibrillation for stroke prevention. So there are a variety of clinical areas where either randomized controlled trials would take very long to provide answers for our patients, or they're simply unfeasible. And it can sort of span not just cardiovascular, which is what sort of I'm currently interested or focused in, but infectious diseases and so on as well.
Thank you. Wonderful work. Congratulations.
Thank you, Dr. Cook.
I was just going to ask you about the sort of integrity of the studies about the label of unprovoked and provoked. You know how sometimes there could be a thrombus and there's a big search and nobody's, okay, I don't know why this person had it. Or sometimes it's identifiable. And I'm just wondering about the time horizon of follow-up in the core studies used to establish the label of provoked or unprovoked, and if that time horizon has any influence on this analysis, and if so, in what direction might that influence the final results?
Yeah, it's a good question. So my MSc and PhD work was with Dr. Mark Roger from Ottawa, who's now based at McGill, and that's one of the things that he always sort of mentioned during thrombosis rounds and debates, that definition of what classifies as provoked VTE, whether it's major or minor or strongly provoked or weakly provoked. And that's one of the sort of the struggles we had in publishing, responding to reviewers in terms of our definitions. So we tried in our systematic reviews and meta-analysis, which inform our modeling study, we used the ISTH definition of unprovoked VTE, which suggests that it has to be absence of all provoking factors, whether strong, weak. It is possible that patients do develop provoking risk factors. We were focused on first event being unprovoked, so the recurrence doesn't, in terms of our estimates, doesn't matter whether it's provoked or unprovoked, but it's true that the definition of the qualifying event as provoked and unprovoked has clinical importance in terms of the subsequent risk.
Maybe I'll ask a question.
Sure. Yeah.
So you mentioned in kind of your concluding statements in the abstract that patient values and preferences should be considered, especially when the evidence is kind of maybe unequivocal and indeterminate, to include those patient preferences and values in clinical practice guidelines. So from my experience with clinical practice guidelines, this is not particularly well done, probably one of the more poorly areas for clinical practice guidelines. How can you envision actually operationalizing that?
I think one of the suggestions that came up during this is to have patients as well as family caregivers on guideline developing panels so that they could encourage the use of certain language that would be important to so that it could be implemented in practice for sure. Yeah.
Hi, great work. This is way outside my area of expertise, but I'd just like to offer that it would seem to me there's tremendous mental health benefit to the patient to being discharged from a lifelong need to take a medication, and the psychology of being sick compared to being well is pretty instrumental in the work that you're doing.
For sure. There is research coming up now looking at the long-term consequences, long-term mental health consequences of VTE and VTE recurrence, as well as stopping anticoagulation and so on. I will acknowledge that for our study, we did not explicitly seek to incorporate measures of mental health and its impact on quality of life in our measures of utility scores and qualities, but certainly acknowledging that there is an increase and more attention is being paid to research on mental health consequences of VTE. Thank you so much.
Thank you, Dr. Khan, and congratulations. That's an impressive publication. Our final postdoctoral scholar to speak today is Dr. Emily Quinn. Dr. Quinn just completed a very prestigious Banting postdoctoral scholarship in health economics at the University of Calgary. She has a PhD in social policy and works collaboratively with health system partners to design and evaluate health policy. Dr. Quinn.
Thanks a lot, and thanks for the introduction. I usually think of myself as a quantitative researcher, but I'm talking to you today about something very different, so I'm happy to be representing the social science side. So today I'm going to talk to you about a series of work where we're engaging Canadians to identify priorities for healthcare reform. So a few key things about healthcare reform in Canada. We need it now. Our performance is pretty poor compared to the amount of money that we're investing into the system. And I'm sure you read every day in the newspaper about problems with emergency rooms being closed and challenges accessing family doctors. It's also really hard. We know that it's more likely after a crisis or after a change in government. And we also know that it's more likely if you engage patients and citizens. So reflecting on all this, I was a founding member, along with Dr. Tom Stelfox and Dr. Fiona Clement, of this Health System Sustainability Initiative, where the goal is to try to identify and mobilize evidence-based policies to improve the long-term sustainability of the healthcare system in order to use the funds we're already investing more effectively and more efficiently. So this is a figure showing sort of the process of the initiative, and we did a series of research studies that then informed a deliberative dialogue at a health policy forum, and then now we're taking those results and trying to put them into action in a few different ways. So I'm going to talk to you now about where we were engaging citizens in this process. So in one of our background research studies, we did a qualitative interview study on Canadians' perspectives on potential reforms. We interviewed 31 Canadians, including 13 citizens, 10 healthcare leaders, 4 decision makers, and 4 academic researchers. And thinking about the Donabedian framework to organize our results, what we found there were a number of structural problems that people mentioned, including the system being more of a sick care system, it being really entwined with Canadians' identity, that making it challenging to create change. And then also people being very resistant of private insurance funding and being really committed to public insurance funding in the system. We also identified a bunch of process problems, including staffing shortages, inefficiencies in care, like leading to long wait times, for example, and then inconsistencies in care, meaning there's differences across provinces that people didn't really understand. And then we also identified actionable solutions to improve health outcomes, including sort of improving the policies to allow providers to really practice at their full scope of practice, and very importantly, enhancing public health literacy. So not just health literacy about like managing your own health conditions, but really thinking about literacy about structural health policies. And then lastly, to really focus more on preventive care, and in doing that, we need to have more interdisciplinary and patient-centered care. So we brought the results from that study along with a study on reviews of international healthcare reforms, and also a study on barriers and facilitators of Canadian healthcare reforms, together as this deliberative dialogue, where we had 12 participants, including health policy researchers, citizens, government decision makers, and health system leaders. This is a picture of our prestigious group that we gathered together. And a deliberative dialogue is a process where you consider research results, and then also another important element is the experience and knowledge that the participants bring to the table. And so we had these research presentations, we had facilitated discussion, and what we tried to do was identify priorities for reform and strategies to enact those reforms. So the three core results were like, we really need a guiding vision for these reforms, and that would include leadership and changes. And then we also, when the changes that we need to make are really based in the community. So we need to have care focused in the community. And then we need to have the community engaged in care in order to really overcome the historic barriers to care. So the guiding vision that really emerged for us was this concept of community-focused health systems. So the implications of the whole first phase of the initiative that I was just talking about today are that whenever we're designing or evaluating and implementing healthcare reforms, we need to think about engaging all players, including the really important role of citizens. We need to reorient the system for primary and community-based care, and then we need to be adaptable and accountable. And how we're moving forward with this right now is that we're engaging in doing a series of pre-election policy briefs, and where we're hosting a couple town halls to really engage citizens in understanding healthcare system challenges and solutions in Alberta. And we're also engaging in a series of work on primary care reforms, and we'll see where that goes. But one concrete example to provide you with is like, if we were able to evaluate the performance of the primary care system and then do public reporting of that to patients, then that would give patients more information about the performance of the healthcare system. So thanks a lot.
Thank you very much, and congratulations, and I wish you all the best in this work. My question is about integration of care. And you know, what we've seen in Alberta is that there continues to be silos of care. And as you try to reorient the system to primary and community-based care, how are you going to try to provide better integration or lead to that concept?
Yeah, that's a great question. I mean, I think that's particularly challenging in Canada. I'm from the US, so there's a lot more, from my experience in the US, there's just a lot more management of healthcare providers, and without that trying to be a dirty word here, I think that like if we could have more of an organization of the primary care providers, not in a way that makes them like employees, but like that still recognizes their individual practice, but could maybe have more connection between them in some sort of governance and management system. So something like similar to Alberta Health Services, but like for managing primary care physicians. And then if you could have more organization in between Alberta Health Services and whatever that governance entity was, then that might improve the coordination and integration.
Thank you. It's so important and interesting. I wanted to ask your thoughts about health literacy, and you mentioned the scope of what you meant by that. In the era where people get so much information from the internet and social media and misinformation, et cetera, what do you see still digital strategies as being the main way people are, shall we say, learning about health, or literacy equating to that, which is digital, or are there countervailing forces or complementary initiatives that might help with any of the elements of health literacy of relevance to what you're doing? I don't know what they would be, but more of these town halls, or is that just a passé notion of people gather together and talk and listen to each other?
I mean, it's an interesting point. I mean, I think, are digital solutions part of the problem? Are they also part of the solution? Like, yeah, I hope so, but I think also reaching out to people just in a human-to-human way. Like, I mean, a town hall is maybe a big event, but it does allow the opportunity for people, like citizens, to actually engage with researchers and policy leaders. So I hope that that's a real event, like a meaningful event, and that we really have meaningful engagement. And I think, you know, we've talked some about, could we have like a social media campaign to try to improve health literacy and health policy literacy. None of us were really communications experts, so that's not where we first chose to go, but I think it would be an interesting idea, and then evaluating how effective that was is something that we really would be interested in. So, I mean, maybe we should think about evaluating how effective the town halls are as well. So, yeah, thanks for the suggestion.
It's amazing. All three of you are really moving towards democratizing science. But I'm really intrigued with the lack of any identification of what's happening with technologies as those technologies merge, and how they're, all of the indications, perhaps not in Canada, but certainly internationally, are that that technology is going to significantly change, you know, who we are as humans, and how we see our healthcare. So rather than having a healthcare system that's focused on chronic care and stress-related illness, if we really do move into technology-based, where we can do more intervention early, how do you bring those kinds of external forces into this kind of work so that it prepares for the future from identifiers that are not currently known? And have you looked at any of that stuff?
That's an interesting question. I think the idea of virtual care being an important component in changing models of care and focusing on more preventive care did definitely come up in the interviews. I feel like you're asking more, like even a bigger question than just virtual care. So I don't think that specifically came up, but I think it's a really interesting point to think about and bring forward in the conversations that we have with people coming up. Yeah, thank you.
Hi, thanks for that really interesting presentation. A lot of the decisions in policy and protocol in medicine end up being predictive, trying to take lessons from the past and look towards the future and predict what will happen next. And in the setting of deep uncertainty, which is a lot of the settings we deal with, it's impossible to predict even what the variables will be in the next decade. I'm wondering how you structure your recommendations for policy leaders around strategies that are robust as opposed to strategies that are based on the prediction of what will happen next.
That's an interesting question. So one of the studies I didn't talk about was actually about how do we give recommendations and how do we do that more effectively. I think some of the things we're doing now is like, if we're engaging all the important players, including citizens and policy makers, as well as providers, and in deciding what those recommendations are, then hopefully the recommendations are relevant to, and those are the people who are thinking towards the future of what we need. I think in Canada, we've been saying the the things that we need now are things we've been saying we needed since the 1960s. So we actually would maybe benefit from looking to the past in this situation in particular. But what else? I mean, it's just a really interesting idea to think about. This isn't exactly a direct answer to your question, but I think whenever we are going to be making recommendations, that we need to make a plan to evaluate them, and I think that could contribute to, are they the right recommendations? Are they helping us now and moving forward? If we actually have a plan to implement them and then to assess them. So.
Thank you so much, Dr.
Thanks.
And I have to say, it gives me tremendous pleasure to welcome Dr. Verna Yiu. Now, the reality is that Dr. Yiu doesn't need an introduction. Every single person in this room knows who she is. Anyone who's delivered health care or received health care in Alberta during the 6+ years that she was CEO of Alberta Health Services knows of the important stability she brought to our healthcare system and the important quality improvement she brought to our healthcare system. Anyone who sort of was outside a cocoon during the pandemic recognizes the incredible leadership she provided and the burden of decision-making she provided on behalf of Albertans, navigating our system through a very difficult public health crisis. Her work's been recognized through multiple awards and recognitions, and I'm going to just highlight one. In 2021, the Medical Post identified Dr. Yiu as the second most influential physician in Canada, behind Theresa Tam. Okay. Dr. Yiu currently serves as the Provost and VP Academic at the University of Alberta. And I can tell you from personal experiences that she's an incredibly generous leader, and we're incredibly fortunate to have her. And I was reminded of that this morning as I was rushing into the building 10 minutes before I was supposed to meet her. And there she was, waiting for me. And so how is it that someone as busy as her is able to make time and dedicate this time for us? So thank you very much, Dr. Yiu.
Thanks very much, Tom. It's a pleasure to be here, and thanks to you and Kirsten for the invitation. Thank you to the Gairdner Foundation, and thanks to the Cummings School of Medicine. I had to lower the podium so I could see everyone. I know that a land acknowledgement has already been made, but I do want to share with you the picture here, which is a picture of the sweetgrass bear. This is by Stuart Steinhauer, and it's in the Quad area for the University of Alberta. And it was placed there in 2016 as part of the university's effort to work towards respectful and meaningful reconciliation with Indigenous peoples. But what I love the most about the bear is that it reminds us all that we are all treaty people. And she's a symbol of the relationship, and on the side is an inscription that reads, "We are all related." And engraved on the bear are sweetgrass teachings of humility, which we heard about from Dr. Cook, kindness, sharing, honesty, and determination. So my talk today is really to highlight, I would say, some of the inequities, I think, of what COVID-19 has uncovered, although these were always inequities. COVID just made it a bit more apparent. And then talk a bit about health equity and health literacy. I've had a chance, as you can imagine, to sort of debrief myself over the past year and really talked about, if we are going to be making a difference towards trying to improving healthcare in Canada, what would that look like? And then that's the fourth objective of my talk, is really to talk about, well, what is the relevance for the Canadian healthcare system? So I would say that in COVID, for all of us, we've learned a new language, because COVID, if anything, has uncovered a level of compassion that all of us are sensing, not just within our own global, not only within our own local area, but also within the global world. And you can see here, this is a quote from Kumar Rafiq, who is a journalist and is a writer based out of London, UK. And he states that in the COVID pandemic, I've learned a new language to show compassion to the pandemic citizens of the lost world. So before I start, I'm ready to talk a little bit about equity and health equity. And the first bullet really comes from a researcher out of UBC, Dr. Katrina Plamondon. And she wrote this very, very good article about health equity and care. And she talks about equity being a goal of a world where all people, regardless of where they are born or what they look like, have a fair chance of living to their full potential. And following that is the WHO definition, where health equity is achieved when everyone can obtain their full potential for health and well-being. And on a global basis, poverty-stricken countries who not only struggled with trying to contain the virus, but were unable to be competitive in the vaccine and the PPE bidding wars. We knew very early on, I can tell you that starting March of 2020, the number of PPE requests that I got in my mailbox were, were next to none. And along with racial tensions, mass social protests, counter-protests, this really led to the reorganization of the global redistribution of power. And in this overview by Katrina Plamondon from UBC, she actually uses the term specifically around global north and global south. And what she means is that global north refers to countries or populations that have been principal benefactors of colonization, and global south to those who have been previously colonized. And we know that the pandemic-related economic strains have revealed really the depth of the globally driven structural drivers of health inequities. Economic fallout was severe enough, as we know, to motivate socially protective policies in virtually all countries. If you recall, when the borders were shut down, we witnessed how the global north stockpiled all the PPE, borders were closed, and we, as a privileged country, had access to health products and vaccines, thereby protecting our economies by making money through their national banks. Versus southern countries, where they were positioned as aid recipients. They were grappling with collapsed global supply chains and what were already severely unfunded social and health care systems, really crippling the debt for those countries, and really resulted in more inequities in regards to the distribution of power. Well, what about health equity and the pandemic? And the global impacts, we know, really are an underestimate of the actual number. Even with the underestimated statistics, one can see worldwide the devastation of the pandemic to date, with over 6.6 million deaths, and in Canada, over 46,000 Canadians who have lost their lives. So who exactly are those who have passed away or been most impacted? Those who are most vulnerable in our society, as we know, and it was, as we saw and witnessed, the poverty-stricken, seniors in long-term care settings, homeless, and those with mental health and chronic conditions, immigrant and refugees, as we've seen in our meat processing plants and agricultural industries. And we also know that the long-term budgeting constraints of healthcare has prevented some of the more innovative things that we've always wanted to do to get us well prepared for the pandemic as we advance along. I also want to highlight how underfunded our social care systems has been. When we think about the solutions for healthcare, it cannot lie within healthcare alone. It has to be connected with our social systems. And as long as we don't have those interconnectedness with those social systems, we can do all we want with our healthcare systems, but I would challenge that we would probably not get to where we want to be. So while COVID-19 is usually thought of as a pandemic, in fact, it can often be called a syndemic pandemic, where the severity of the pandemic is magnified by the existing inequalities in chronic diseases and the social determinants of health. We know that the increased levels of chronic disease and inequalities in health terms have led to higher infection and mortality rates in disadvantaged communities. And disadvantaged communities such as minority ethnic groups and people living in poverty, as we know, faced higher consequences to the COVID after effects and COVID deaths. And the longer term and largest consequences for health inequalities will be connected to the political and economic climate. Evidence from the 2008 financial crisis suggests that the austerity measures and rising unemployment rates have worse health impacts on communities that are facing disadvantage. And really, to prevent the pandemic from from increasing health inequalities for future generations, it is really, really vital that the right public policy responses are undertaken now, because we know that there's going to be another pandemic right around the corner. So this is a study that was done by Kwame McKenzie out of U of T, where he created a Black equity working group because what he noticed was that he had a sense that there were worse effects, especially amongst the Black populations. They knew that was happening in the US and the UK, and he wanted to examine the work that was in Canada. And you can see here that, in fact, the work that was done out of Ontario affirmed that there was indeed a higher incidence in racial groups, leading to specific interventions that they subsequently created. This was an interesting study that was done by Kim McGrail out of UBC, and what she wanted to do is that she used publicly available data to explore excess mortality related to COVID-19 from March 2020 through to October 2021 to shed light on the population-wide effects of the pandemic and variations across the country. And you can see here that excess mortality was calculated as percentage of total observed mortality, and similarly, COVID-19 deaths were calculated as percentage of total excess deaths. And you can see here that excess mortality rates in Canada during 2020 and 2021 varied widely by the province, according to this publicly available data. The eastern provinces, in fact, had the lowest number of excess deaths, including a proportion actually in the negative range, indicating the mortality was lower than expected. And the three most western provinces had the highest number of excess deaths as of October 2021, prior to the Omicron wave. And the deaths that were varied across the province, and one of the things that we don't really think about was the impact of the opioid crisis and how the western provinces had access to opioids that the eastern provinces may not have had. In fact, may have been a compounding effect of that. So when we talk about health equity, as someone asked the question about predictive analytics and maybe looking forward versus looking backwards, the history of healthcare actually tells us what the solutions are. There is no magic in knowing what the right solution is for fixing our healthcare system. And you can see here that health equity, as defined through the IOM or in 2003, and 20 years later, we are no better off in addressing health equity. So why is that? Primarily related to the fact that there's been a lack of translation from high-level policies into change into the healthcare delivery systems. Fundamentally, that is the major issue. The other aspect that has been challenging is that we don't really do enough on the upstream component of health. We talk all about acute care medicine, and at the end of the day, if you're going to find bang for your buck is going to be upstream. And I just want to highlight one of the things that we talked about in the comment about digital health and can digital technology be a solution? Absolutely. When I think about Connect Care and the power that Connect Care has, I think one of the challenges, though, is that it can also be an access barrier for those who may not have smartphones, for those who may not have the ability to have internet. What about those whose English is not the first language? Marginalized populations. So regardless of the types of solutions that we think we need to have, we need to consider health equity in all different aspects. So this is a conceptual framework for action on the social determinants of health. So as I mentioned, health equity is achieved when everyone can attain their full potential for health and well-being. And they are determined by the conditions in which people are born, grow, live, work, play, age, as well as biological determinants. And structural determinants such as political, legal, economic, with social norms and institutional processes shape the distribution of power and resources determined by the conditions in which the people are born, live, work, grow, and play. So people's living conditions are often made worse by, as we know, discrimination, stereotyping, prejudice based on sex, gender, age, race, ethnicity, disability, or other factors. And discriminatory practices are often embedded in institutional and system processes, leading to groups that are often underrepresented in decision-making at all levels or underserved. And so progressively realizing that the right to health means systematically identifying and eliminating inequities resulting from differences in health and overall living conditions will ultimately be the better for all. So this is a really nice review that was done by the WHO in 2018. And what I really liked about it is that it really describes health as a life course approach. There was not just an incident at a time. It is related to the entire functional ability and the intrinsic capacity through the life years. So functional ability enables well-being at all ages and is determined by your intrinsic capacity in physical and social environments, and by the interaction between the individuals in these environments. Intrinsic capacity is the sum of all the physical and mental capacities, follows a biologically determined trajectory of these capacities. So in order to truly deal with health equity, we need a better shared understanding of how individuals' health and well-being are shaped by multiple factors, and how the risk of ill health can accumulate across life stages and generations. And one of our major obstacles is often we tend to focus on single diseases or specific age groups rather than holistically addressing health throughout life. A life course to health also encompasses strategies across an individual's lives that can optimize their functional ability, thereby enabling well-being and realization of their rights. Because we know that resilience to ill health and the risk of ill health accumulates throughout life and across generations. For example, 70% of preventable deaths from non-communicable diseases have been linked to risks encountered and behaviors that started during adolescence. And so key to this life course approach are really the social and environmental determinants of health, which, as we know, includes health systems, but also essential public health functions, multi-sectoral factors, and cross-sectoral actions. So if you want to implement a life course approach, this is kind of what you need to really think about. You need to think about policy and investment, the health services and systems, but very, very importantly, the local, multi-sectoral, and multi-stakeholder actions. We have to shift from a health policy to, as what was already commented on, a health public policy, where the impact of policy should be focused on well-being across all government sectors. I used to say that the Ministry of Health is but one ministry, that every other ministry is also a Ministry of Health, because no matter whether it's in education, whether it's in seniors or housing, all of it ultimately relates to health and well-being. So I'm just going to move next to health literacy, and I really have always felt very strongly that health literacy amongst the public is actually very poor. And health literacy is absolutely critical for us because it is not just about having the knowledge and the motivation and competencies, but you have to have the confidence and the skills to seek out, to interpret the information that you gather, understand the concepts of risk and benefit associated with different lifestyle choices and in healthcare treatment options. And COVID really showed us in real time how poor health literacy is and how dangerous it is when one is not trained or provided with adequate information, or to be able to interpret in a way that actually not only supports your health, but everyone else's health. I think everybody's sort of seen this slide which talks about health outcomes, and you can see here that health behaviors accounts for about 30%, social and economic factors 40%, physical environment 10%, and of course acute care is about 20%. So, you know, as I mentioned, we spend a lot of time on that 20%. But in order to deal with health equity, we need to focus on the 80%. And health literacy actually links all of these 4 different buckets together. So I'm just going to chat a little bit about health literacy and why. So I would consider health literacy, and I think it's been mentioned already, that it is really a social determinant of health. It helps bridge more equitable health care and results in more equitable health outcomes. And we know that it's very detrimental to health. There's a large body of evidence that shows that low health literacy is prevalent around the world, is associated with a range of adverse health outcomes, including unhealthy health behaviors, ineffective use of health services, and poor health status. And just as I said, think about the past few years with COVID. Health literacy is key to understanding everyday health decisions, decisions on washing hands, decisions on maintaining physical distancing, on complying with quarantine policies, and thus contributing to a more successful public health response strategy. And this isn't just an issue for low-income countries, but is prevalent for high-income countries. In fact, the best country for health literacy is Denmark, and where they have probably pretty good health literacy in about 50% of their population. That's the best, 50%. Canada is probably around 40%, but really there hasn't been any recent study that have looked at that in Canada, and it's very, very dated. So if any of you want to do research in this area, it's really ripe for doing that. But what are the outcomes for low health literacy? Well, you're twice more likely to die within 5 years than older adults if you've got low health literacy. More likely to have serious adverse events as it's related to patient education. And 7 to 17% of personal health expenses is attributable to low health literacy. Examples of impacts includes poor nutritional knowledge, behaviors, high obesity rates, more medication errors, ED visits, asthma knowledge, and behaviors and outcomes are poor, less likely to use preventative services, and poor management of chronic illnesses. Having difficulty performing tasks that are essential to maintaining health. And I think for us, when we think about that, we tend to overestimate what people understand. I'm talking about inability to maybe even fill out the basic information on some of the forms that we send out to patients. I'm talking about not actually understanding what TID is versus breakfast, dinner, and before you sleep. I'm talking about really being able to even read about understanding valid health information and not being able to interpret warning labels. So if you think about all of that combined, it's no surprise of the impact of low health literacy. So, which is, I'm a pediatric nephrologist, so of course I have to talk about parents and children. And parental health literacy is also crucial. If you think about the fact that low health literacy in parents affects children as it relates to injury prevention, feeding, nutrition, smoking, alcohol behaviors, physical activities, violent behaviors, children with chronic health conditions, medication compliance, and even for children health literacy is important. Children and young people need to be empowered to take control and make decisions that can influence their own health. And we know that children who have better health literacy not only can influence themselves, they tend to have a healthier diet, they're more active physically, they're more resilient. So when they grow into adulthood, they're going to have a lower chance of having mental health issues. So really the focus on children and young adults have to begin in early life course. And fundamentally, my belief is that children who are literate in health actually will impact their own parents and actually help them become more literate as parents. So what are the benefits of improving health literacy? Everything. It increases your patient safety, improves your health outcomes, as I mentioned. It helps you live healthier, increases your engagement, and it saves time and money. There was a very interesting study that looked at the cost of healthcare costs in low literacy in the US, and the estimate was in the billions of dollars that people were wasting because they actually were not health literate. So what are we going to do to improving equity and health equity? I would first of all say that it takes all of us to be part of the solution. And adding health equity as a fifth aim is really potential, is needed to really move our quality improvement efforts. But what's very, very important is that we're going to be adding health equity as a fifth arm to the quadruple aim. We have to be very careful in terms of how we do that. First and foremost, we have to know that, as I mentioned, it goes beyond health, right? It includes societal impacts, environmental, educational, and economic factors that affects the healthcare. And quality improvement initiatives has to be explicitly designed to improve health equity. Interventions that are evidence-based and proven to reduce health disparities, as well as ensuring that people from those affected groups and communities are part of the planning. We talked how important it was for patients and families to be at the center, not just in terms of their care, but also in terms of anything that is planning in terms of delivery. And then the fact that this will require overcoming challenges with addressing upstream social determinants of health, including obviously better need for data, and sharing data and investing in, obviously, measurements going forward. So when the quadruple aim came out as part of the Alberta Health Services Health and Business Plan in 2017 to 2020, I was really, really proud of our quadruple aim. I remember having a visit from IHI at that time, and they were trying to convince me that triple aim was where it was at. And I said, no, you can't do triple aim if you don't have people at the forefront. And so we were very, very proud of the quadruple aim, but I would challenge now, with the COVID hopefully well underway, that we have to move beyond the quadruple aim. The equity piece is actually embedded in the quadruple aim, but I think more than anything with COVID is really shown us that we really need equity to be at the forefront. So I really like the quintuple aim for healthcare improvement, and that it's really important to make sure that we actually embed that. In terms of health literacy strategies, there are quite a lot of them, and I'm just sharing you, as a clinician, these are the things that we all should be doing, which is really about engaging the people using some very simple, plain language, clear designs. Visuals tend to work very well. Infographics, teach-back techniques is very useful, and as I said, patient-friendly resources to enhance training. And how do we know it makes a difference? Well, we do know that when you use interventions like this, with using health literacy-informed strategies, it does improve in several areas, and these are just examples in vaccine knowledge, in child injury prevention knowledge, and in obesity prevention. And we do know that in acute care, when you actually improve health literacy, there are explicit benefits. So again, just some examples here. How do you use it? Syringes, simplifications, use of teaspoons, use of pictures, and again, low literacy, easy to read health aid books. Those have been shown to reduce emergency visits by as much as 30%. So I just want to end with this quote, which is from Paulo Freire. He's one of the most influential philosophers in education of the 20th century. He's Brazilian. And he wrote this book called The Pedagogy of the Oppressed that was written in 1968. You can imagine with a title like that, how it was banned in several countries. But I would hope that we would all want to imagine a world, especially now, that is less ugly, more beautiful, less discriminatory, more democratic, as we heard about, less dehumanizing, and more humane. And so with that, thank you so much for your attention.
Thank you very much, Dr. Yiu, for an outstanding presentation. So we've got time for about 10 minutes of questions. And so I'll ask people to go up to the, so I think you can stand up, Katrina, and go to one of the mics. And take advantage of having Dr. Yiu here. We've seen her on TV and in the press. This is a chance in person, so take advantage. Katrina?
Thank you so much. Can you hear me? That was amazing. You're speaking my language, and anytime I hear a health professional talking about social and structural determinants, I get so fired up. I'm really fired up right now, so I'm trying to be articulate in my question because I have so many things I want to say. But I appreciated your comments around health literacy, and I wonder your thoughts on building social and structural determinants literacy within healthcare. Because to me, that's the other side of the piece of this where, like in my work, I do a lot of research on homelessness, domestic violence, bringing health, and in particular Alberta Health Services to the table in terms of accountability for social determinants has been really hard. Yeah. So I wonder your thoughts on that.
Yeah, I would say that one of the things that we've been fairly purposeful about when I was in HS was really trying to build those, what I would call hard fixes into the system so that it's not dependent on having to educate. And so when we think about Connect Care, Richard Lowanchuk, who many of you would know, was tasked to actually do that within Connect Care. So there are some aspects of Connect Care where you actually do put in data and information on social determinants of health. One of the really important reasons for doing that is the ability to track, but it's also an ability to sort of provide some input into knowing the types of patients that we serve, and if there are clinical best practices, is eventually to lead that into clinical decision support tools They've also been building into the Connect Care ACEs and also for children. So I think those are some very important aspects that will put it at the forefront when it comes to patient care. That would be independent, I said, of education, which is useful, but it's just not good enough.
Okay, why don't we take a question with the lower mic first, and then we'll go up to the upper mic. Lower mic.
Oh, I apologize. Sorry about that. I thought you said we're on the floor. My name is Magdalena Muir, and I work on social determinants of health, particularly in the Arctic and climate. And I guess I wanted to raise just the question, we've come through COVID somewhat. What's your view on things that are really going to be broad, like climate shifts, which are going to have a lot of impacts across all populations in Canada and globally?
Sorry, what was that?
What would be your view on, based on the experience you've had with COVID, what would be the impacts in the future of the broad scale change we're going to see arising from climate, which we've already started experiencing?
Sorry, the last one, was it climate,
yes.
Oh,
please.
climate change.
Yeah.
Oh, sustainability. Yeah. I would say that, fundamentally for us right now, sustainability has always been a challenge, right? I would say that sustainability from a healthcare system, maybe not climate related, but sustainability from an economic perspective. In Alberta, we've actually done quite well. And for those of you who aren't aware, I'm really proud of the fact that in November, when the latest CIHI data, so I'm detracting from your comment, I'll get back to your question, but that in November when CIHI came back with the NHEX data, which is about cost for healthcare, cost per person, Alberta is no longer the most expensive system outside of the territories. Thank you very much. In fact, I think we were number 6 now. So we're now in the middle of the pack, and that took a lot of effort, and that's part of sustainability. I'm not sure about climate change from the perspective of COVID, other than to say that we've done things differently now that we will continue to do. So climate change as it relates to travel, I'm not seeing that there will be a lot of travel in the future. I think we're doing a lot of things by Zoom. So I think that fundamentally changes how we are. And that's probably about all the comments I have about climate change. Thank you.
Great. Thanks, Dr. Conley.
John Conley, thanks very much. I really enjoyed the discussions about health literacy. Just looking at this as an underlying theme, when you look at the recent OECD data on excess mortality post-pandemic, latter part of 2022 and 23, Sweden is at the bottom of the list now, which was much maligned, and they're around 3%. Canada is still sitting at 7 to 8% with all of the issues that you mentioned about the opioid after effects from the pandemic and other things. And Denmark's very low as well. Is the health equity issue the underlying piece, or is it that plus social determinants of health that are maybe better in the Scandinavian countries, and particularly Sweden, which took a very alternate approach to the pandemic? I'd be interested in your thoughts. Thank you.
Yeah, thanks very much, John. I would say that when we compare ourselves to some of our, the European countries, they do a much better job, in my mind, on connecting the social determinants of health and connecting health with social agencies, social care, education. Those countries are very different from us culturally, so it's very hard sometimes to kind of compare some of those health outcomes. But we know, as we know, a lot of the health outcomes is really not so much related to the types of clinical care we can offer. I can guarantee you that in Canada, we can offer the best clinical care anywhere in the world. But where I think the gap is for Canada is that we just don't link anything together with healthcare. So the issues around homelessness, the issues around poverty, in a country that's as wealthy as Canada, we should be seeing much better results when it comes to that. Education, the de-emphasis on the importance of post-secondary education. It's very distressing now that I'm in the university to see that that sort of reduced attention and reduced importance that the policymakers have on things that we know will make us better as health outcomes. So I think it's probably a combination of the fact that they are very different. They have different values than Canada, and I think they do a much better job with the social determinants of health.
Dr. Roy.
Thank you for a very interesting presentation. I think this morning we've had a lot of themes around humanism, and to some extent, COVID really raised a question of individualism versus collectivism in terms of how we plan for problems. And the health inequities that you mentioned. You focused a little bit more on the regional health inequities, things within our healthcare system. And I think the COVID pandemic had some challenges that were shared across the world. And one of the things we saw was sequestering healthcare materials and vaccination capabilities within countries. And Canada is not exceptional in that way. We were administering third and fourth vaccinations to people in our own health care system when other countries had not yet been vaccinated at all. And this struck me as not only an example of health inequity, but actually not a very good strategy, because a lot of the changes in the viral genome occurred in countries that were partially vaccinated at very low vaccination rates. South Africa is a good example of a country that had very poor uptake of vaccination, and we saw virus mutations that ended up being really important here. I'm wondering if you could talk a little bit about how Canada or Alberta could be part of the inequity changes that are needed on the global scale, and what we can do during these times of crisis that reflect our humanism in making sure others have access, and how it affects us here at home as well.
Yeah, I would also add that it wasn't just inequities globally, there were inequities within Canada between the provinces and the territories. And I would say that, you know, the worst time to sort of plan is during a crisis. There's no ability to plan other than sort of trying to get through the next day. But surely as a world where we actually saw how the global interactions and connectedness occur, that we, as a member of this earth, we need to come together. I mean, at the end of the day, there's got to be some abilities to come broader, you know, for, I don't know, whether it's at the WHO level, whether it's at the United Nations, we need some sort of global agencies to really do a bit of deep debrief around how we can actually deal with this into the future, because this will happen again. One of our big challenges we knew around the PPE distribution piece, and I'll just use that as an example, was that, you know, at least in Alberta we were prepared, and there were others in the country that were less prepared, which is why we're able to give PPE way out to Ontario and Quebec. But we knew with our modeling within HS that that there were going to be major struggles. And I'll just give you an example. This is just an interesting statistic. In a typical day within AHS pre-pandemic, we're using about 44,000 surgical masks in a day, right? 44,000. At the peak of the pandemic, guess how many masks we were using? 750,000. So if you had no ability to know what that burn rate was, how do you then predict 3 to 4 weeks in advance? So some of the information that we do need to work on better is the data, the sort of the integrated data that we would need to have. And as I said, in Alberta, we're lucky we had that provincial data. Very few other provinces who weren't centralized didn't have that data. But I would say globally, we would need that. PHAC definitely needs to sort of improve their data because, again, there were major issues with even trying to come up with anything on a national basis. But I would say that we would have to plan going forward. And another pandemic is not going to be in 100 years, right? John Conley?
Okay, so we've come to the end of the session, but I think what we'll do is I'll just make an executive decision to extend here. We've got lots of good questions. So why don't we keep it to the 5 people who have been brave to stand up. We'll give them a chance to ask questions. What we'll do is we'll alternate starting at the top and then to the bottom, and we'll alternate through these final 5 questions.
Good day, my name is Fedir Asimenko, and I wonder about patient navigation as a strategy to address health equity. Do you think there is a role for patient navigation within our healthcare system to actually tackle some inefficiencies and especially reduce the disparities among the vulnerable populations?
Yeah, I mean, patient engagement is absolutely key to any health system. I don't think that any health system who is going to be a learning, high-performing healthcare system can exist without the patient engagement, without patients at the forefront. I mean, patients are the users. If we don't actually help address some of the user system issues, then what are we doing? Because as providers, we definitely don't know what are all the challenges that the patients encounter. Although we can be patients ourselves, and let me tell you, I hear a lot about that part, about how we can do better. So patient engagement is absolutely critical going forward, and I think it has to be embedded in the system. So, for example, again, in AHS, we have a provincial patient family advisory group, and when they first started about 10 plus years ago, I would say that people were very nervous, healthcare providers were very nervous to go to patients to ask for input, because they didn't want to hear it. They were actually afraid to hear it. It was actually intimidating to hear it, kind of interesting, because you'd think that it'd be the opposite, that patients to be intimidated to speak to providers, and it wasn't. It was the complete opposite. And before I had left AHS, I can tell you that nothing was done without the patient family advisory group being aware and informed, including COVID decisions, visitation hours, usage of PPE, everything that we put forward in policies had patients' stamps on it before we proceeded.
Dr. Marlette?
When I saw you were coming today, I kept thinking it'd be interesting to see how the change from being the boss of a health to being the boss of a university was possible, and how you're going to take advantage of it. And so I've been thinking, as you talked, about this topic in particular and how it relates to a university. And I'm going to give you just one small example and see how you react to that role. And I guess the thing that has excited me about education is that it allows us to engage people before they become patients in health equity. And so one of the organizations I'm working with is Ashoka, which is an international network of change makers that began in the universities and have moved now to being able to teach children in elementary school how to do community-based research and to really understand the importance of research in their communities. And I've been really kind of intrigued with the fact that we have very few Ashoka-based universities in Canada. And I'm just wondering if you've ever thought about sort of getting the before patients involved in health equity.
We need to talk. Just to say the boss of university is a lot less stressful than a boss of a healthcare system. But I love your concept, and I've been trying to actually bring some ideas to university. So one of the things that we're actually embarking on right now, which I'm very excited about, is actually doing a student experience action plan. So something fairly comparable to patient experience, but students as the users and the learners within the system, I don't know of many universities that have actually looked at student experience to the degree that we're going to be doing, and really taking it from the context of how to try to improve the student experience. So we're starting with that, but I love your concept about the health equity piece. But like I said, we need to talk if you don't mind.
Judy Birdsall.
Thank you. Judy Birdsall. I'm one of the founders of a nonprofit called Imagine Citizens Network, and our mandate is to help all of us as Albertans have a more effective voice in shaping the future of health and healthcare. So in various roles, I've sat in rooms with people like this for the last few months talking about how to improve primary health care more recently in many hours. And so I sit in rooms like this and hear about the social determinants of health over and over and over. When I go to rural Alberta, which is where my roots are, start talking about health, I hear about hospitals and doctors. And so I'm actually looking for some free advice, Verna. How do we move from where we are with citizens to having all of us as caregivers, me, and my family and friends, engage knowledgeably in these conversations? It's a huge challenge, I think, And we have had, AHS has done phenomenal work of inviting and embracing patients. And my group was working with primary health community at the time, trying to close that gap a bit. But I hope we're not aiming to a system where we have two silos, one for illness care and one for primary care. How do we bring them together with a citizen voice? How do we build agency and ownership and some power among Albertans who actually pay and, as you say, are the intended beneficiaries? So thank you.
Yeah, thanks, Judy. So we know we've gone out to rural Albertans and asked them, what is it that you want from healthcare? And the number one answer is they want access. They don't care that it's quality access. They don't care if it's actually, if you just do one cesarean section a year, it doesn't matter to them. They would still go there. So that's part of the challenge, is that that's all they think about. And what we have not done as a province is that we have not had the conversations with the rural communities about what does care look like for you. Because it may not be a hospital. And so in my old days, I was chomping at the bit to go out to rural communities to talk to them about bringing forward information about demographics, about what the anticipated load is going to be around chronic diseases, some of the prevention things that we can do, and really have a good discussion with them about what healthcare is going to look like 10 to 15 years from now. And what is it that you need in order for you to be healthy? And unfortunately, what happens is that the cardiac cath lab comes up. And, for every one person that I save from the cardiac cath lab, I could actually save 28 people if I actually invested in primary care. And so that's the disconnect, is that we have not gone out to have had this dialogue with citizens in Alberta. And that has been the challenge. And so no wonder the focus is on hospitals. No wonder that the hospitals is their economic driver, and I understand that. But we've never gone out to say, you know what, we need to provide you with a foundation of primary care because you will be looked after better that way. And without that, which is part of health literacy, in my mind, that's what we need to do next, Judy. So,
thank you.
Dr. Rabi?
Thank you. Doreen Rabi, I'm a diabetes care physician here in Calgary, and just wanted to echo Dr. Stelfox's thanks for your generous service and leadership. And I wanted to, one thing that was sort of alluded to but not spoken about directly in your talk, which I enjoyed a great deal, was the issue of power and income inequity, and how massive power differentials within our healthcare system, within our academic institutions, also is a bit of a driver of inequity. And in particular because healthcare is a situation where patients and clinicians it's inherently inequitable. Clinicians have an elevated status in our society. Many patients are disempowered, and they're there because of chronic and the accumulated disempowerment that they've experienced in their lives. So just your thoughts on sort of, the role, we have as advocates, as clinicians, as citizens to address those power differentials, and how, lost my train of thought. We'll maybe start there. And if I have the part B comes back to me, I apologize.
So thanks for the question, Doreen. I absolutely agree with you that there is a huge power differential. And the game changer here is actually knowledge and data. I mean, one of the big challenges is that when patients come and see clinicians, they're coming in blank, right? They don't know what their lab data is showing. They don't know their x-ray or pathology. They might have Googled whatever they thought they might have had, but at the end of the day, knowledge is part of that power imbalance. And for me, that was one of the best things about Connect Care, was that it actually brings the patient in the forefront. If I now have access to all of my data on my smartphone, I can actually control, I can actually text my team. I actually think that as part of Connect Care, one of the best things that we should do for the system is to actually enable the patient to actually invite people to their circle. Why is it that we all have access to all patient information? Should the patient not have control over that? Should I not be able to say, I want Dr. Yiu, but I don't want Dr. Rabi? That type of, or vice versa. But I just think that patients have not been in a position to be able to do that. And having data and knowledge is going to totally reverse that. And that's what we need to do. We need to enable Canadians to take ownership of their healthcare, because we can only do so much in the healthcare system. By the time you come into the healthcare system, it's too late, right? In many respects. It's all upstream, all preventative. It's about what you do in your free time. And that's what we need to really encourage. And, we're baby steps right now, I would say.
Yeah. And sorry, I got my follow-up. Sorry. I guess the question I have with that, and I completely agree, and I think that everyone should have access to their health information. They should have some say in the governance of that information, and that information needs to be protected. I do wonder, though, about if we don't specifically address that power differential, though, the agency that patients feel that comes with that information may not be there, and wondering, in terms of when we're looking at sort of the statistics on health literacy, whether that might be a sign of disengagement or resignation related to the fact that they have been so disempowered for so long.
You're absolutely right. I mean, the system that we've built over decades has actually resulted in that, which is why the child health literacy is so important. I just can't emphasize that enough. And right now, we don't actually have the structure to do that, because the educational system doesn't feel like they have the expertise to teach the health, and we're not invited in as healthcare providers. So we need to somehow provide that link with the educational system to say, let us help you. Let us help you develop the curriculum. Let us try to help inform our young kids. That's where the future is, in my mind.
Okay, to bring us home, Dr. Beal.
Well, just to pick up on that issue of agency, and thank you so much, by the way, for your presentation. Amazing. The choices that we make are shaped by the choices that we have. And how are you going to avoid some saying, well, they're behaving that way just because they don't know better? There's some issues we're not going to educate our way out of without proper attention to the underlying determinants. And so I'm wondering, how do you toe that line within political circles and not let people off the hook?
How much time do we have, Tom? I think there are things that we can control and things that we cannot. All I can do is do what I do best in the sphere that I'm around and try to control that piece and try to influence that piece. And there are others where, all I can do is just provide my advice and you either take it or not. All I can say is that the May election is critical for us as a healthcare system and will absolutely determine where we go. In the next few years, I would encourage everyone. I'm not answering your question, by the way. I'm just asking everyone to vote and vote where it matters the most, which is for our future of our children. So thank you very much.
Okay, great. Thank you very much, Dr. Yiu. So we're going to move on to our next segment, which is the final sort of group segment, which is a fireside chat. Talk about the personal, organizational, and systemic change in health research. So I'm going to invite Dr. Yiu and Dr. Cook to come up here to the front. And then I'm going to introduce our moderator. So we're very fortunate to have Dr. Todd Anderson, who's kindly agreed, come up, grab seats, has kindly agreed to serve as our moderator. All of you will know Dr. Anderson. He's a cardiologist who's cared for thousands of patients through the clinic, in hospital, and through interventional procedures. He's a health researcher who trained at Brigham Women's Hospital in circulatory physiology and has led national guidelines on cardiac health. And he's an academic leader. He's dedicated decades, literally, to academic leadership here within our faculty as well as nationally. And he currently serves as the Dean of the Cummings School of Medicine. So please join me in welcoming Dr. Anderson.
Well, Tom, thank you for that too kind introduction. So it is an absolute thrill for me to be here. I have the great privilege of being the Dean of the Cummings School, but to be with these two fantastic clinician leaders And to see all of you out here and all the engagement and the questions is wonderful. So we're going to dig right in. We got about 30 minutes or so. So the theme is change. And so we have the opportunity to ask these two individuals how they navigated personal change, change within their structures, and change at a societal level. And that's the remit for us today. So I have some questions that I can ask, but the microphone is open. So if you have questions in that theme, okay, I know that you have lots of questions otherwise, but if you have questions within that theme, and we have a participant right off the bat, so please.
Along the lines of change, I'm personally in a pretty large career change. I've been a nurse for over 20 years, and then I'm currently doing my PhD and moving into a more research academic role, and trying to navigate how to maintain engagement as a frontline clinician while also working in a more research academic field, and how to balance that.
I would like both of you to respond to that, but great question.
Thank you. I too have always found it important to stay at the bedside. I don't work in a clinic setting, but at the bedside, all of the energy and inspiration, caring for the patients and talking to them and their families has been a guiding force in my scientific pursuits. And it's been one of the most obvious decisions I've made, and I've never, ever regretted it. And yesterday morning, I was 3 hours in emergency, and one of my long-term friends came up to me, also practicing, and said, "Are you still practicing?" And I said, "Are you?" And I've never regretted that. So to the extent that that fuels you, I think that's a great choice, and stick with it. And when it doesn't work, like everything in life, our decisions change when they don't seem to be working anymore. The net benefit doesn't outweigh the cost. However that's measured, let it go. But I've found that to be essential.
So I would absolutely agree with Dr. Cook about the fact that it's really important to stay grounded in your roots. And, you know, both of us, I'm sure, trained like years to get to where we are. But I definitely didn't train to be a provost. Didn't train to be a CEO either of AHS. So, you know, I've always actually maintained my clinical practice. I've been very fortunate to be in an incredible group of pediatric nephrologists at the U of A, Stoller Children's Hospital, and the only 2 years I wasn't able to work was actually during the pandemic. The first 2 years I just couldn't handle it. So, but up to that point, I've always been doing clinical work, and I am actually back doing outpatients now in pediatric nephrology. It really does, it gives you the reason as to why you're here. And if you don't stay connected, it's sometimes easy to lose sight of that. So it's really important to keep grounded.
Hi, I'd just like to say thank you. Very inspirational to a young woman in science, so thank you so much. I guess this is more on a societal change, but in the last couple of years, we've seen an attack on science, on health policy, on research in general, and just wondering how you've navigated misinformation and, you know, the fake news working as clinicians and researchers.
Do you notice that? She's very good. You know, if anything, COVID really taught us the importance of research, didn't it? I mean, evidence was changing almost on a daily basis, and so it was very, very powerful. It was just that it was too fast, and you just didn't have any ability to sort of think about what you were doing, because it was just you had to make immediate decisions. I think the best advice I could give about misinformation is that it's going to take all of us to correct the misinformation. And we have to be comfortable in addressing that, because there is I mean, I think we were in trouble when Trump became president, and then we all heard about fake news, and I was thinking, what the heck is this fake news? And then it kind of took off, didn't it? But I do think that we each have a role in our own ability to correct misinformation in the networks that we have. Because clearly when we as, whether it be the experts or the leadership or whatever positions we're in, you're always going to be seen as skeptical. We know the most powerful source of ability to make change in somebody else's minds is actually your peers. And so even for the most anti-vaccine types of people, who's going to make a difference to making them change their mind is going to be their friend, not their physician, not their nurse, not whatever. And so I think each of us has a role to play when it comes to combating misinformation.
Yeah, that's a great question. For me, in the intensive care unit, it was, right in our face, caring for patients who'd either, for various reasons, maybe didn't get vaccinated, and some clinicians early on, and allowing the discussion to go on in the break room and in the hall and just at the bedside, trying not to objectify people, trying to respect different points of view, started the conversation I think a lot of us took home. And probably everyone involved in healthcare, there were dinner conversations about vaccination and people's masking and et cetera. And it's sort of it became, I think, being in healthcare for many of us in the ICU setting in Ontario anyway, a platform that forced us to discuss misinformation and choice and normalize the dialogue, and many people I know took on advocacy roles and worked through their anger, and it was just allowing the entire conversation because it was so in our face, the intensive care unit. And I think a lot of people otherwise, would not be discussing healthcare when they were having their Christmas dinner with their family and chatting over coffee with friends. So inadvertently, many healthcare practitioners brought their voice to the discussion of misinformation, and one of my challenges was trying to come up with strategies to not just say, yes, it's morally injurious and we have moral distress, but what are the resources and what is the role that each of us may have in this platform to try to guide people to different sources, express ourselves, and be part of the conversation. So that's not something that's happened very much before. But in the ICU, it's just so in our face right now.
Thank you.
I'm Huda Kwan, and then it's really glad I'm here, I really, my personal, I through all of the surgery because of my cancer, through the surgery, and then I got diagnosis and do the all test. And also I'm learning literacies, and then I say I'm literate for my disease and for my procedures. AHS website is wonderful, and read it. And then I understand some part, but some part is really hard for me. And then I do I'm epidemiologist. I do a lot of the big data analysis. I publish so many papers using confidence intervals. I give the 2 examples and then say how we can changing the cultures research from presentation of the result from public use to the individualized patient useful. One example I had, and then I did one of the bone density, and then they give me the result, minus 1.6 SD. And then that is my conclusion. And they say, what is SD? They will say, standardized deviation. Helen knows really well. I do not know what's mean of this. So how we can shifting this kind of information is patient more understandable. This is one. Second way, when I read the papers published for my disease and then read, I really like to read. Some parts say, same my condition, same my situation, and then what happened for these patients. They only give the mean, average, and range. It's not enough for the patient. How as we AHS, Community School Medicine, promoting really precisionalized medicine or presenting individualized information for patients' use?
Well, there's an easy question. Who wants to start with that one?
Huda, good to see you. You look great.
Yeah.
So I'm going to extrapolate it to the issue that I've seen since I've, rejoined the university, which is, there is a disconnect between what we think is relevant for the public versus what the public feels themselves. And our inability as a university to translate our research into something that's actually useful for the public to understand is an issue for universities across the country. I think one of the reasons why we are having struggles with really getting the support that we need for post-secondary education is that the public doesn't really see our relevance, right? So what? This Cumming School of Medicine is doing great work that you're doing, Huda, but so what? And so I think we, as an academic, as an academy, need to do a much better job at our communications and at our branding. Actually, U of C does a great job at branding, to be honest. But
Thank you, Verna.
you're welcome. But what we need to do is that we need to show our impact. And the only way to do that is to actually talk in the type of language that the public does, because we sure don't do that right now. Even in the way that we advertise our talks or promotion of events, it's way above. And so we need to show our own relevance so that we can actually get the supports that we need in the public dollars that we receive. So I didn't really answer your question, Huda, but that's okay.
Yeah, that's okay, that's okay.
Deborah, you're good? Yeah.
Just going to say, I think the discussion about visuals for the public is important. You're talking about your bone mineral density report, and having recently had one of my own, I was very impressed when I received my result, and it was low, medium, and high, and it was all very visually portrayed, and I thought that was useful. And it reminded me how in the acute care setting, so many of the results are communicated verbally and people don't know what the heck it means, and especially in the intensive care unit with all the devices, and we've all talked to people, say after 3 weeks they're ventilated and someone's obviously on life support, and then someone mentions life support and they go, my mom's on life support? Because it just hasn't been communicated. So I think more of the visuals and patient-friendly, family-friendly information, vehicles and pamphlets and that sort of thing on websites as well is important and overdue.
That's great.
So this isn't to put anybody on the spot, but I guess it leads me to the question of engaging patients, and I'm assuming that everybody that's here is because they want to engage patients in their work. And I'm a patient, and that's why I'm here. And I'm privileged to be a part of the patient advisory group that you were a part of with AHS, and a number of research networks across Alberta and Canada. And I guess my question for you guys is, what is one of the biggest pieces of advice that you would give these guys in the audience? I could give advice all day long, just in case you're wondering, about the most effective way to engage patients in the work that you do over the last number of years.
They're fighting to see who gets to go first.
As I said, I think that for patient engagement in any health system, it has to be seen as the norm and not as the add-on. And that's a culture shift, and that takes time. So as I said, when we look at the Patient Family Advisory Group, thank you so much for sitting on it. As I said, no policy would end up, or a procedure would end up coming to the executive table if there was not that agreement or green light from the Patient Family Advisory Group. So people knew, but that took time. Like, it wasn't always like that. It took time for people to understand, oh, you know what, we need to get patient input on this. And if it wasn't ready, the Patient Family Advisory Group would say, you know what, it's not ready, you go back and fix it and you'll come back. So it was actually a very powerful group from the context that they could stop things from moving forward if they actually didn't think that things were appropriate from a patient perspective. But like I said, it has to be embedded and seen as part of the everyday activities and not as an add-on or as a tokenism. And like I said, that takes time. It takes leadership to actually recognize that too.
Alberta, as everybody here knows, has been way, way ahead of the curve in honoring and eliciting and honoring and promoting, supporting patient and family engagement. And as a scientist, I have been late to that process. But I started with perhaps picking a very obvious topic, end-of-life care. It's everybody's business. And that has helped fuel in our community, in the ICU community anyway, help make everybody realize the importance of the process. And starting with one topic that very clearly is compelling to everybody has helped us branch into other projects. So just to understand, there are people still struggling to meaningfully make this engagement happen, and it does take a change of culture and a change of faith, and I just think it's a lot to demand all at once, but it's important to have some sort of sentinel projects in a portfolio that then move the field. So I just know you're ahead of the curve, and please keep showing everybody how to do it. I've been watching.
So I work from a health equity lens, talking more about like a QI-related work surrounding patient and family engagement from a pediatric standpoint. Actually, I represent both University of Calgary as well as McMaster in that work, but some of that work has had me inviting families to presentations both through the UN, talking about the rights of children as well as disabled people, talking at the House of Commons specifically about the importance of engagement and things like that, and the reactions are varied in terms of the story that it tells and the impact that it makes. How do you, what are things that you recommend when it comes to the notion of resistance to change? Like just to, in terms of impacting and what that means too. Because part of that really important aspect of the work that has gone on with training, because that's what we do. We bring researchers together with people with lived experience, and they learn about having quality relationships. And part of that really ends up being they don't see the point, but there's benefits even from a health literacy standpoint, because you move from an objectivist myth of knowledge, where it's just like an expert pushes that information out to the world, to having people who interact with that information and suddenly they see a bigger, broader world of what the health system looks like. So how do you address resistance to change in helping tell some of those stories?
Just one idea that sticks with me from reading many, many years ago, and I'm embarrassed I don't remember the source, but it's an old study. It has to do with farmers adopting different types of grain. And you probably know about the curve, the change curve. There's early adopters and there's laggards, and people who don't want to change and people who, are leading the way. And when there's any time there's something sort of new or exciting, or I'm thinking of a change, there's a tendency I think people have, and I have had to focus on like the naysayers and how that, not really, or people sort of going against that. But I always try to focus on the people who are the early adopters, in this sense, the whole of the province of investigators here, as we've been talking, for patient and family engagement. But follow the early adopters, work with them, find like-minded individuals, always listen to the naysayers and the laggards, because they teach you where the holes are in your argument. They may guide you like, don't do that yet, focus on this now. You always learn talking to people, and it's great to understand the viewpoint of naysayers and folks who don't want to change or don't want to follow a new initiative, whatever it is, but to affiliate yourself, not with everyone who thinks the way you do, but people who are leading the field, even if you have a slightly different take on it. So to your question about change, in my mind, I'm always imagining the people on the curve, where you want to go, and then who on the curve you want to listen to when. And if you're always focusing on the negative, or this is too hard, or this can't be done, not much change occurs. And the other reality is sometimes you have phases and parts of your life where you are a laggard. For me, I was late going from a BlackBerry to an iPhone. And so I was a definite laggard there. I was late learning how to send an attachment on email, even though I was the early adopter of email. And in so many other ways, I've tried to be the change agent and be the change that I want to see. But we can't all be, in all aspects of life, change agents, but we should attend to everybody on that spectrum. Those are my thoughts on change and people.
Yeah, so I totally agree with you about, focusing on the early adopters and not trying to waste your energy on the naysayers, because the naysayers will come along, right? If you've got enough people moving in the direction you want. But two comments. One is that when you approach people, especially from an advocacy perspective, you want to approach people with that sort of win-win mentality, that no matter what lens they have, that there's a win in it for them. That's my first advice. The second one is that it's nice to personalize it, because we can present all the data. This is what I learned in my 6+ years as CEO of HS with government, is that anecdotes always wins out. That I can present all the data that I want, it makes all the most sense, There's a lot of evidence in it, but man, that one person from up north who shares that story about the bathtub in Lacrete, I mean, you know, that just wins out and will stay there forever. So try to personalize it, bring a narrative, a story to it, see why it's relevant for them, and then see if that brings it along, and if it doesn't, then move on.
Go to the back microphone.
Thanks very much. David Swan. I'm someone who spent 10 years in primary care, 10 years in public health care, and 15 years in politics. And I guess what I want to say is that the lion or the elephant in the room is power, and it was alluded to earlier. And the shift that needs to happen in determinants of health. What I experienced in 15 years of politics is there was very little emphasis from the professionals on determinants of health. I heard a lot from the AMA, the Medical Association. I heard a lot from the Nursing Association on their own career trajectories and their training. And the focus continues to be 95% on clinical, hospital, medical, rehabilitative services. We are not getting to the 75% of the determinants of health that determine people's health outcomes. And there's a reason for that. The people in power, the professionals, us, are not advocating to politicians for the determinants of health. It's very simple. Follow the money. 5% of Alberta spending goes into prevention. And determinants of health would obviously, including education and some of those other dimensions, are important. But the big budget that's continuing to increase is clinical medical care and technology. So I guess it's a reminder to me today that we talk a lot about, as Judy Birdsall said, we talk a lot about social determinants of health. We don't advocate politically as strongly for that as we do for more medical care. And to be fair to those who are called not so well educated in the rural communities or just want hospitals and doctors, they're just doing the same thing that doctors are doing, advocating for more clinical services. So it's no wonder that nothing is changing in the bigger picture of funding for prevention. Thank you. There's a sort of a question in there.
Well, I can tell you, so David, good to see you. I can tell you that, you know, for at least the time that I was there, you know, our budget was quite constrained for acute care. So we actually got an accountability letter every year that highlighted the amount of budget that we were allowed to have within each of the buckets, and acute care was the lowest ability to move. So there was some purpose, and in fact, if you were to look over the last 6 years or so, the amount of money that we have been spending, for example, in seniors care, community care has been slowly increasing. And acute care has basically been flat, despite the fact that there's been higher need for capacity. But the way to address capacity is really trying to improve your quality of care, right? And I mean, Tom Noseworthy and leading the strategic clinical networks, that's done a huge amount of work to increase capacity, which is what we've been able to do within the system without increasing the budget. So it can't just be you keep the acute care flat because of all the demands, but you have to make sure you're purposeful around the quality improvements piece. And I absolutely agree with you, David. I think one of the other big elephants in the room is sort of the funding mechanisms around physicians. Of course, physicians are going to advocate for more services, like cardiac cath. I'm sorry I keep coming back to that, but that was painful to have to try to counter that. We should be investing in primary care. But you know, people are going to want the technology, they're going to want the hot items for their local settings. It brings people in, it brings employment in. There's other consequences that are not necessarily health related, and those are part of the political other influences that we have to grapple against. But you're absolutely right, we all need to do a better job about what we need to do is the right thing to do if we want to keep our healthcare system sustainable.
Two more questions, Maria.
I'll try to be brief. It's just about change. So
So for example, in terms of engagement, patient engagement, right? And so we have the money from SPOR in mid-2000, and then now we have the second funding. And so I see, for example, the support that we provide to researchers, clinician researchers, to engage families, patients, youth in their research from when we started now. I mean, the increase is unbelievable. It's really, I'm an optimistic regardless, but I'm basing this on numbers, on evidence. And so it's great to see that now we are looking at health equity. So we are bringing people that are not usually brought up to the research, health research environment to gather their thoughts, exactly what Deborah was saying, like, what do they need? What do they think? And all the work that you've done, Verna, I mean, like, engaging, and we have work on different pieces, right? And so I think this trajectory, and I go like, gosh, we're doing so well. And like, I see it in Europe in other meetings, and they invite me to talk about what we're doing here. And I go like, we might be doing something good, right? But then with all my optimism and everything, go like, yeah, we're doing so well. But then I go like, we are not showing it. How can we translate this? How we can ask Albertans to translate Canadians, translate these efforts, the successes, for example, the stories that you started in NHS, like the patient's narrative. So I think that there is maybe an opportunity. Of course, we need to work harder on this. But for Huda, my dear friend Huda Kwan, that like he was talking about, they gave me these results, and I'm Huda Kwan. I didn't understand it, and so it's just like we have an Alberta for Health Research network for more than 4,000 people interested in working with us in research, but they do not understand the language. And so exactly, so more work done on that. So working with the data gurus sitting on that right and somewhere else, to bring that. But the KT aspect, how do we translate that to the universe and said, this is what we're doing. What is the change, the next thing that has to happen?
How about a school under the auspices of the University of Calgary to promote all those great ideas, to invite members of the public, we're all patients, as we've pointed out, but to learn, disseminate, create an even larger cohort of people to lead the way, to get engaged in all the projects that are going on in this province, to be a resource for the Canadian community, to have people to learn how to disseminate sort of lay reports, the social media, educate more people to do more of the research that's already going on, and lead the way. Build a school within the university here.
Thank you. So can I just quickly add that one of the real big strengths for AHS and the SCNs and scale and spread, right, Tom? When I think about for example, the inappropriate use of antipsychotic medications in long-term care, one of the major reasons why it was so successful in the scale and spread was because there were major champions. One champion at each of the long-term care sites. That was, I don't know, over 100 long-term care sites that it expanded to. So if you extrapolate that to beyond the province, then you need sort of local champions to really drive that and use Alberta as the model by which they can learn from. But that would be my recommendation to you.
Thank you. Thank you so much. We have 2 minutes. Short snapper, please.
All right, I wrote it down, so hopefully it makes sense. How might people convince an organization to change and develop more iterative learning health systems, including their health system influences and social determinants of health, based on human and patient experience within the confines of their provincial and central mandate and directives? And so I'm not speaking necessarily about spreading ideas, which you just talked about, but how to actually change the organization when you're a small change agent and perhaps don't have a formal position of power or leadership or belong to a small program.
One idea is the power of the anecdote, the power of the story. the narrative. Narrative represents data. Everybody can get a narrative, can tell a story, start with a story. It's connected us all from the beginning of time. Stories to create the platform as one early step.
Yeah, I kind of hear what you're saying. You know, it is I mean, at least within Alberta, AHS is a huge organization, right? But, you know, like I said before, I think everyone has their own sphere of influence, and you don't need to have a leadership title to lead. So I really believe strongly that everyone should be building their own leadership competencies, regardless of what they do in the system. And it's sort of through your network that you actually can start making those types of influence and change.
Thank you.
So please join me in thanking these two individuals for a great session.